wonderful job.
Okay, thank you. Good evening. Everyone can hear me?
Yes.
Yes.
Yeah, good evening. It's a pleasure and privilege to be here on the third day of the ISHKS 2022 virtual meeting. And yesterday and day before, it was well attended and very wonderful discussions. And today it's also a plethora of lectures, some scientific, some philosophical, and we got a great national and international faculty. Mohit Bhandari from Canada is going to speak on a very vital topic, work-life balance. And Kelly Vince is talking on another important topic. Arun is talking on how to ace the academics. And we got a great panel, Bharat, Sriran, all the people I can see. And so it's wonderful to see you all here without much ado. And Nilesh, can you take over and run the proceedings, please? As flawlessly as your quadriceps pairing approach.
Thank you, Guruva. Thank you. I think it is a wonderful opportunity for all of us. As we all know, some years ago, there used to be 6 to 9 movies. You know, in any city that you go, there was a movie that started at 6 o'clock and ended at 9. So we are going to have a 6 to 9 movie on all aspects of hip and knee arthroplasty without the actual surgery. And believe me, there are a lot. As Guruva said, we have a plethora of speakers, work-life balance, building a brand. Then we have interesting symposiums on infection, periprosthetic fractures, and medical management and pain management. So may I invite the opening batsman for the day, Dr. Simon Thomas, to talk about what is in and what is out in total knees and total hips. Dr. Simon Thomas, for you.
Good evening, sir. Good evening, everybody. Okay. What's in and what's out in TKR and THR? Let's see what the literature says. A lot of literature has come out in the recent past. Let me run through a few of them. If you see at PRPs for OA knees, they are not cost effective. According to the study, no significant clinical efficacy for improving pain component, and it does not delay TKRs. If you see UKRs versus TKRs, UKR surely has a lower healthcare cost up to 10 years, but if you see the revision rates at 10 and 5 years, it is higher. UKRs in obese, in morbidly obese patients, UKR has higher clinical failure at 2 years, as early as 2 years, without any significant difference in infection compared to a total knee. If we look at the cemented versus uncemented UKRs, cementless components have more subsidence at 1 year, but once they reach the 2 years age, there is not much difference left. Obesity and total knee replacement, these patients experience significant improvements after TKRs. And morbidly obese patients, although they improve symptomatically, but there's more chance of revision. Still, do not withhold arthroplasty in these patients because even after preoperative bariatric procedures, the chances and the risks of revision are almost the same. Diabetes and TKR, use of metformin reduces all sorts of complications in the postoperative period, including reduction of hospital stays as well, as per this study. Tunicase, they reduce the operating time for sure, but they also increase the risk of adverse effects. They are more painful postoperatively, and sometimes they increase the hospital stay. Thromboprophylaxis is aspirin, as effective as ever. It is a wonderful agent. Even low dose and regular dose work similarly. Comparison of aspirin and rivaroxaban, the risk of VT is comparable in both, but aspirin has surely a better bleeding profile. Pain management by use of steroids, a combination of IV and periarticular steroids, they improve pain control significantly without increasing in wound complications up to 1 year. Gabapentin versus pregabalin. Pregabalin is better than gabapentin any day for reducing post-operative pain and reducing opioid consumptions. CR versus PS, it's a matter which is debatable. but no significant in recovery and knee range of movement as at 1 year follow-up as per this RCT. Vitamin E poly, not much of use. Vitamin E poly generated, in fact, more smaller particles than conventional poly as per this study. The subvascular approach was taken into consideration in this study, and they found higher incidence of proximal wound dehiscence and delayed healing by the subvascular approach. Robotic TKR, the immediate post-operative at the time of discharge, the patient satisfaction seems to be higher compared to conventional approach, but at 10-year follow-up, no difference in survivorship and clinical outcome. Post-operative antibiotics, extended use in high-risk patients for 7 days. The high risk includes diabetics and morbidly obese patients. It reduces the infections up till 1 year of primary TKR. Povidone iodine lavage, a weak povidone iodine lavage, and vancomycin powder infiltration in duru along the fascia reduces PJIs immediate post-operatively. Titanium implants were perceived lighter by 30% of patients, but there was no difference in range of movement or pain perception post-operatively. Coming to the hips, the surgical approach is approach the culprit in dislocations. The meta-analysis comparing DAA to the posterior approach showed no significant difference in the rate of dislocations in this study. The posterior capsule repair, only 50% remains intact after 1 year of THR as per this MRI study, but there was no dislocation when the capsule was intact, and 2 out of 15 dislocated in the dehiscence group. Head size, 32 appears to be much better than 28 to reduce dislocation. The dislocation rates are comparable between 32 and 36, and the rate of revision rises with 36. So 32 mm appears to be the flavor of the season as of now. Vitamin E poly in THR, as in the knee, no significant difference in wear rates at 5 years for vitamin E versus conventional poly, whenever you're using a 32 and a 36 mm head. Ceramic on poly versus COCR on poly, the 5-year follow-up is comparable results with very, very low wear rates in both obesity and THR. Unlike the knee, hip patients are not very amenable, and BMI more than 40, there's a very high chance that these patients may not improve functionally after total hip. The elderly, higher rate of revision with uncemented stems due to fractures and dislocations, and recommendation is against the use of uncemented stems in ladies more than 75. THR or Hemi for hip replacement for elderly fractured neck or femur, no significant difference in incidence of secondary procedures, but THR seems to be slightly better in function over 24-month period. Robotic THR, patient-reported outcomes measure at 1 and 2 years show no difference, but the surgical time is higher. Thromboprophylaxis, aspirin is as effective in low doses as well as higher doses, and it is comparable to other anticoagulants. The tranexamic acid, the optimal dosage, 2 gram IV preoperatively with 3 post-operative doses of oral 1 gram each, which causes maximum reduction in blood loss. Post-operatively, patients with good normal hemoglobin of more than 13 and electrolytes, they don't need a repeat of post-operative investigations as per this study. The dilemma in patients who require spine fusion as well as THR, the precedence in these patients should be given to spine fusion, because whenever they undergo THR first, there's always an increased risk of dislocation, PGI, and revisions. This was a summary of some of the landmark papers that have been there in the last few years. Some of the above slides were strange to me also, but then what's brand new today may be obsolete tomorrow. So that's why we are here for. Thank you for your patient attention.
Thank you very, very much, Simon. That's a great summary of all the important papers. I think we can get on with the next item on the agenda, which is a symposium. Is Rajesh Manyar there? Yes, Rajesh is there. I can see him.
Yeah. Do you want me to share my screen?
Yes, please, Rajesh. Please.
Okay. How do I? I'm not allowed to share the screen. Wait.
It was there.
Rajesh, it was there.
It appeared for a moment.
Doctor, you can share.
Yeah. Now? Yeah.
Yeah, we can see you. We can see periprosthetic joint infections after total knee. Yeah.
Yes. Well, good evening, friends, and thank you very much, Nilen, for this opportunity.
Rajesh, I'm sorry, we can't really see your screen right now. Huh?
I think it is loading. That's what it is showing here.
Yeah, now we can see it. Yeah.
Yeah. So we have an eminent faculty with me today, and I think I'm going to learn from them as much as you all. But there are some rules. I think first we want short answers so that we can complete a lot of things that we want to say here. Second, please don't repeat what is already mentioned. And finally, I think for the next half an hour, my word is final. We had a task of covering prevention, diagnosis, and management. I think prevention is by itself is a big topic and would take the whole symposium. So I think I'll leave that and we'll start with diagnosis. So what I'm going to do here, Bharat, Subhranshu, and Kalaiwan, and I hope everybody is on. I can't see them. Subhranshu and Bharat I can see. Okay, so I think what I'm going to do is I'm going to present some facts, and then if you have any comment to make or any point to make, please raise your hand so that I can see you, and then we can stop in between and have your comment on that. So, and then the second part, we come to the case presentation, where of course we will all ask you questions and go ahead. Right. So here, early infection. I think we will all agree that acute and early post-operative infections we would consider are within 4 weeks of surgery, and acute hematogenous are within 3 weeks of starting the symptoms. If a patient has got 4 or 5 years later infection but doesn't come to you within that 3 weeks period, then we should not really consider that as acute. How do I go? Yeah. So all of you will agree that 3 most important things to diagnose that acute infection is WBC count, more than 11,000, most of which should be neutrophils, ESR, which is non-specific post-operatively, at least up to 3 months. And that again, it can be variable with the age. And I think it is most important to know the pre-operative level of the ESR. The CRP is important. Again, it takes long time for it to come back to normal. There are other parameters like interleukin 6, which peaks earlier than CRP and returns to normal by 48 to 72 hours. And we presented our study on this in Knee Society, and it was published in CORR as Knee Society Proceedings a couple of years back, which shows that the CRP is late to rise. By about 48 hours it peaks, whereas the IL-6 peaks at 12 hours and comes down also very quickly. By 96 hours, it is almost down, although slightly higher than the pre-op level. But it still could be very useful in early post-operative diagnosis of infection. But that still needs to be studied. Only thing is it remains a little expensive test and not available everywhere. What remains the final diagnosis is culture and sensitivity. The point here is to collect it aseptically without having a contamination and collect it in appropriate bottles for each item: aerobic, anaerobic, fungal, tuberculosis nowadays, and whatever else that you may suspect in that in conversation with the microbiologist. Important point to make here is a single dose of prophylactic antibiotics does not alter intraoperative culture results in PGI. We were traditionally taught that you should start antibiotics only after collecting your samples, but a single preoperative dose does not matter. And I think preoperative dose otherwise is a very important one. So that was the conclusion of this paper. Here I wanted to ask everyone, does anyone use leukocyte esterase test? Bharat?
I don't use it as a normal. I usually depend upon that culture sensitivity as my real indicator. So, yeah. But I have used it once in a while on a ward level, hospital ward level basis, and it's useful. But I don't decide my final pathway forwards just on a leukocyte esterase test.
Right. I think it is a very useful test for some other infections, urine and other. Do it on the site. It has not caught on so much on the knee front, and there has been a lot of changes in its accuracy. sensitivity and specificity over the period of time. Although this study here recently says that LE is a rapid, inexpensive, and can be performed at the bedside. And if it is leukocyte esterase 1+, then it rules out infection. If it is 2+ or more, it's almost certain of infection. So I think from that point of view, it is a useful in acute setting. Self is not able to see my slides. I'm not able to see. Okay, so in an acute setting, does everyone agree to this, that if it is truly an acute infection, you have a go at debridement and irrigation? Subhranshu, what do you think?
Yeah, if the infection is within 3 weeks of the index surgery, or
Yes.
within 3 weeks of onset of symptoms in acute hematogenous infection, then DIAR is the procedure to be
Correct.
done. Yeah.
And it should always be combined, if possible, with exchanging the poly.
Yeah, if you have modular components, then you have to extend the polyethylene.
Because there is evidence that if you don't do that, the recurrence of infection is higher.
Yeah.
As such, it has at the best about 50% success. And if you don't do that, it'll go even further down.
Yeah.
Would it mean, Rajesh, that if it was a monoblock tibia, I mean, in the sense, not a modular component?
No. Then you would not exchange it, because that would mean it is a one-stage exchange.
Mm-hmm.
It's
The problem is that when we do DIAR, whenever you do a debridement and take out the synovium, etc., there is always some amount of laxity, and you have to put a thicker polyethylene.
Yes.
So modular components, I don't know. I don't do big monoblock components, but modular components you have to exchange, and you have to keep thicker polyethylene always ready for exchange.
Yes, very good point. And the full revision, I think, in only certain situations in this acute most of the time DIAR, but unless the organism is such, or there is some other history that tells you that probably a 2-stage would be better in this particular host conditions as such. Okay, let's go further. This is what I was mentioning. This study has identified who will fail the DIAR procedure, and the four most important are positive blood cultures, high CRP, no exchange of modular components are done, and time from index surgery. Earlier, the better. The moment you know that there is infection, even within that 4 weeks, earlier you attack it, better it is. So here is an example. This patient came to me 6 weeks after the primary surgery. The surgeon had put him on antibiotics, etc., and this is what it looked like. Would anyone, 6 weeks from the prior surgery, infection, almost 6 weeks, would anyone attempt DIAR?
I would still give it a go.
I always explain the patient that while doing DIAR, if I find the components are loose, then I'll take it out and put a cement spacer. Here, APVO is not seen. I have to still check the index X-ray, immediate post-op X-ray to compare, because I see the anterior flange of the femoral component. Not happy with that. There is some.
Yes. So, but I think the AP alignment also was good. There was no problem. But at 6 weeks, I go very strictly. If it has already taken time, I decided to do 2-stage. And this is when I opened, there was frank pus like that. So anyway, here he is after 2-stage. This was many years back. And so it was a static spacer. Okay, now let's talk of more important late TKR infections and present some cases. I don't know how I get the panel out of my view. This is coming in my own.
Go to view options.
You can minimize.
Go to view options on the top line bar. Rajesh.
Yeah.
Go to the top line of your TV screen, of your computer screen. You will see the view options. Drop it. Do the drop down.
Okay, I'm not able to do it, but I
Doctor, click and hold it and move it to the side. It will come as vertical on the side.
Yeah, thank you. That works. Okay, so 74-year-old female, post-TKA, at 1 year she comes, unrelieved pain, increasing symptoms. I think no-brainer. There is a lot of synovitis, swelling. You can see some radiolucencies. So I aspirated grew Enterococcus species. And this is on the table, really dirty looking tissues. I sent post-debridement, sent tissues for culture, and this is what the tissue grew. 2 more organisms, Klebsiella pneumoniae and Citrobacter poceri. Kalai, are you there?
Yes, sir. Hi, sir, I'm there, sir.
Yeah, so does this bother you? Is that something you see? Any comment?
Yes, sir. Yeah, like most of the time, it's always a polymicrobial rather than a single organism. And especially nowadays, it's like quite common, gram-positive and gram-negative combination. And generally, we have an ID consultant opinion to decide on the antibiotic. And we go with a multi-drug resistant approach. We also talk with the microbiologist and choose the best antibiotic, which is with the less side effect, and address whatever the organism is there.
Correct. I think the most important point is to be vigilant. The again, now this is coming in my way. Okay, so here we treated all the 3 as required. 2 stages.
Can I make a comment, Rajesh?
Yes, yes.
Yeah, in the culture report, always ask for the MIC, or minimum inhibitor concentration.
Yes.
No,
yes.
only sensitive, resistant, doesn't give you an idea that which antibiotic is more sensitive, which antibiotic is less sensitive. So if you have a MIC value, then it gives an idea that which antibiotic is preferable.
Correct. I think it is very important. This article looked at the polymicrobial infection, and they say that suspected if the onset of the infection is early, post-surgery immediately, if it was a post-traumatic arthritis, or if a patient comes to you with a sinus tract. And they've actually, it's a very good thing, they've studied the type of organisms that occur in the single organism or a polymicrobial situation. And the point they say to remember is this, that in addition to coagulase negative staphylococci and enterococci, which are the most common in a polymicrobial infection, like we had in our case, it's Corynebacterium species and Finegoldia magna. These are the common ones. But always suspect it is the key thing. All right, another patient, 72-year-old, 2 years from total knee, severe pain and inability to weight bear. Again, you can see that this doesn't look really a pristine joint. Tibia is already loose. Infection. This is the initial fluid aspirate. Did not grow anything on a standard culture. No other AFB or fungus seen. But the key thing again is to wait. 14th day, it grew fungus. Candida glabrata. Again, Bharat, not a very uncommon thing. And I think many of the infections which are not diagnosed, probably fungal culture was not done. You comment?
Absolutely right. As years went by, I realized that once threshold to suspect fungus and therefore request a culture for fungus has come lower and lower. And I have been only happy as and when I have made that as part of my demands from the microbiology people.
Correct. So I think, and as Subhranshu mentioned earlier, MIC value is must. The 2 other most important antibiotics are amphotericin B and voriconazole, which is later given orally. You can also consider fluconazole. Amphotericin B, Bharat, do you use that in the cement? I think that's the one which you can, it has the stability pattern is such, heat stability, that you can use it in the cement.
Yes, but I have not made it part of my routine practice, to be honest. So.
No, not in the routine practice, but if you are revising a fungal infection.
Yes, of course. If we are talking about treating an infected revision sort of a situation, yes, of course. I thought you were asking about
Voriconazole also can be added to the cement. Voriconazole and amphotericin B, these are the 2 antifungal antibiotics which can be added to the cement.
Yes, but voriconazole is most of the time available as a liquid, right? You need to get a special powder form to get into the cement. Yeah.
Yes.
Yeah, voriconazole is also available as tablets, as you know, for long-term administration.
Yeah. So okay. So here, the other thing to remember with the fungal infection is that once you take out that cement, etc., there's going to be a big gap. There's lot of bone destruction. This is the tibia, and this is the patella, and of course you can see the large amount of the cement spacer that went in. And I revised it in 2 stages. This is 1 year post surgery, and currently she is much longer than surgery. Now, I want to ask this, Subhranshu, that what do you do if you get a dry tap? You have a patient post first stage, when they come up, most of the time it is dry, or sometimes even in a primary, this thing, you couldn't get much. How do you proceed with that?
If my ESR CRP values are, in a decreasing trend, or it has come down to normal, and when there's a dry tap and clinical examination shows no signs of inflammation, probably that is the time to go ahead with the second stage. But having said that, whenever there is a fungal infection, I have to treat these patients with antifungal treatment for minimum of 6 months. That with the consultation of the, the infectious disease ID specialist, fungal infection.
You mean between the two stages, 6 months? I think probably that's too long. But overall, 6 months, yes.
Yeah, overall 6 months. But when the ESR CRP has a decreasing trend, comes down to normal, and there is a dry trap, there is no signs of inflammation around the knee. Pain is okay. Means, of course, with cement spacer, there will be little pain, discomfort. But then I go ahead with the second stage.
Right. So now,
sorry, to pick up on that point of Subhranshu's mentioning 6 months, if I could just bring it to our attention, that the Philadelphia consensus statement, that exhaustive exercise that was taken by, so these timelines between two stages, it has now been established that there are no solid data to support whether 6 weeks or 6 months. These have developed initially as an intuitive thing. And I think what you just now said, that it's a bit too long. If you think that the overall other indicators of that clinical situation suggest that the infection has resolved, we can go ahead and do a second stage earlier. These are very important points.
I think I'm going to come to that. I'm going to come to that point in a minute. Here, the point I wanted to make was this, that if you have a dry tap, there is a way out. You can put 10 to 50 ml of saline in the joint, of course, under a very sterile condition, and re-aspirate. And the report shows that the positive predictive value and the negative predictive value of this dry aspirations and the, after putting the saline is same. So it is the dry aspirations where you put saline and the standard aspirations, they have the same value. So I think it's something that to remember. I often do it, and it's something that might help you. Okay, here, going further, bilateral total knee. This gentleman, a doctor himself from Indore, and had bilateral total knee, and both got infected, Staphylococcus aureus. Naturally, you can't leave them both in, so I had to do both simultaneously. Remove the implant, debride it, and put a articulated spacer. Here, faculty, everyone uses articulated spacers now?
Not necessarily. No, I mean, I use a static as well.
Okay.
Except when the knee is unstable, when you cannot get a primary stability, it's better to put a static.
Too much of a bone loss.
Yeah, too much of a bone loss, then better to put a static spacer.
So when not possible, of course, you can't put articulated, but whenever it is possible, you would put an articulated, right?
Yeah.
Yeah.
And what is the reason why you would not put an articulated?
To be honest, because most of the time my 2-stage interval is only between max 6 and between 3 to 6 weeks, and therefore I have, cost-wise and some other aspects which are not necessarily with microbiology or related.
Okay.
I do use static.
Okay, I think we need to go faster here to complete what we have. So in the re-implantation, I did it in 2 stages. This is first stage on the right side, left is still the articulated spacers. I think it gives fantastic range of movement and a comfort to the patient. This is after both knees were revised, infection-free and good function. So this is the point that the studies show, in fact, meta-analysis, multiple studies show that when you have an articulated spacers, the infection rate is actually lower. And I think that in the initial years, I held off putting articulated spacer, thinking that infection, you need to give rest to the part. How can you let it move? But believe me, the literature shows infection rate is less, and it is easy for you to aspirate the knee. There is some fluid there, and it is also easy for you to expose the joint. So I would recommend that wherever you are able to put that.
Yeah.
Similarly, flesh sterilization of component and reimplantation is a viable option, and a lot of people do it. I particularly don't. I've come across some of the cases. This surgeon put the autoclaved implant and a pulley, which was new, but patient continued to walk on that. At some point of time, had a medial condyle fracture. That's when I told her to have a revision surgery, but she continued to walk on that and had even further collapse. We then had to do a re-stage 1 followed by reimplantation. She is here at 1 year. Up to 4 years, she was infection-free. Then she got an infection again, chronically suppressed, and ultimately, finally, she reached a stage where I think there was no further way out. She'd gone to, I suggested a possibility of revision or an amputation, and after that, I have not seen her. Anyway, you mentioned amputation and they'll go away. So here is another patient. Yes, Bharat? You're saying something about amputation. Most of the time, people don't want to accept it.
Oh, no, I agree with you. I mean, unfortunately, I have not had any amputation but the patients usually would go away once you discuss it.
I've only done it once, but I've advised to at least half a dozen patients and they just go away. This is another patient, again, had an autoclaved implant surgeon put, and you can see that medial condyle because they continue to walk. At 2 years, came to me with a condylar fracture. Okay, so, but that is an option. Now, the point we were trying to make, 2-stage, 6 weeks antibiotics, 2 weeks of antibiotic holiday, aspiration, and second stage if the aspiration is clear, and repeat first stage if the aspiration is not clear. I think, Bharat, you would agree with this, except that the timeline may be different for different patients.
Yeah, you're right. Absolutely.
Monitor with CBC, ESR, CRP, and general health.
Yeah.
And this is again debatable after second stage, how long to give the antibiotics. I think it has come down. I had started giving it only for 2 weeks, and currently I think just 5 days probably may be enough for many of the infection.
I give it for 2 weeks. During the second stage also, I send multiple samples from femur, tibia, and parapatellar gutter, suprapatellar pouch, etc. Sometimes, rarely, in some of the patient, I find only one sample becomes positive. In those cases, I continue 6 weeks of antibiotic or else 2 weeks of antibiotics if all the reports are negative.
Right. Okay. Some more interesting cases here is a bilateral TKA, male patient at 6 weeks had pain, swelling, decreased range of movement. At 3 months, the aspiration was done. I think it was delayed. The surgeon should have aspirated it earlier. And since no organism identified, there was a further delay. Finally, at 4 months, first stage revision surgery was done, although there was no growth. But during the surgery, samples grew this Cocuria rosea. And the patient was treated for that. With whatever, according to the antibiotic. And at 10 months, patient came to me. This is when he presented to me, where his range of movement was only 3 to 15 in spite of the articulated spacer. So it was a stiff. ESR was borderline, ESR borderline. Bharat, what would you do at this stage?
Presuming that the CRP is still a bit high, I would still worry about persistent infection, do aspiration, and try to establish whether it is there or not. If not, then of course second stage might be.
Right. So this is what I did. I aspirated. There was no organism, but I was still suspicious because there was a tenderness and induration you can see at the lower end, and that was sufficient enough for me to, and the stiffness that the patient had. And so I did a repeated first stage. And this is what we found. There was a cavity here with pus. And when we removed that pus, there was a ledge of bone which really needed to be removed. But more importantly, what we found that it grew rapidly growing non-tuberculous mycobacteria. And this is what I want to bring up here, that we must remember this organism today. Also, the second fact that we grew it in a sonication of the implant. And that's another very important point I wanted to bring up here. Of course, this patient was treated for 6 weeks, whatever antibiotic appropriate, and for 3 months needed for the, they don't need 1 year or 1.5 years. They need a 3 to 6 months treatment based on the profile of the organism. Now, diversing here, the sonication, it has been shown that it has a higher yield rate, and therefore I think you should include it in your armamentarium. Okay, coming back to our patient, definitive reimplantation was done after that AKT treatment, and here at 1 year following the treatment, infection-free and excellent knee outcome. We've reported this case in JBJS. It's only the second case that has been reported in the literature for knee infection. But my point here is to remember that organism. And here is another patient. Young patient, total knee, in 1 month needed debridement, culture had no growth. Three months, the histopathology showed Mycobacterium abscessus, this organism. The surgeon did the first stage revision, and again, patient ended up with me 6 months later. I repeated the first stage. And when the patient came for the second stage, there was a fracture on the medial condyle of the femur as well. Therefore, needed a two-stage, second stage. I used a distal femur replacement tumor prosthesis. Here she is a year after, infection-free. So you can easily, and here she is 2 years. It isn't advancing. Okay. And so important thing is to remember this organism, look for it. It is very common to have this organism when there are multiple surgeries happening and the autoclaved instruments are opened up even before they dry completely. And that's one of the main reasons why this happens. Okay. Now, quick word about single stage exchange. I think it is slowly becoming more popular. Traditionally, it had a lower success rate. However, the recent reports show that the reinfection rates and cases are comparable with both groups, but there are no prospective or randomized study as yet. Gold standard is still a 2-stage. But these are the recent report from them that say that the eradication rate may be similar. The most important points, they say that we should remember that this is the international consensus in the meeting, that criteria for single-stage arthroplasty is that the organism should be preoperatively identified and organisms should be susceptible. Kalai, do you have any point to make? Do you do single-stage?
No, sir, we believe in 2 stages right now.
Correct. Most of the time I do 2-stage as well. Bharat, anybody? Sudhanshu?
90% of my...
Yeah. Yeah,
90% of my cases go through a 2-stage.
Right. And Subhranshu?
I don't do single stage, but one of the important points, host should be immunocompetent host. Patient with diabetic, rheumatoids, etc. Yes. When the immunity is depressed, one should not try for a single stage.
Correct. So here I have listed the criteria that various University College of London or Endoclinic has given. All want preoperatively identified organisms and susceptible antibiotic, but Infectious Disease Society says they should have a good soft tissue, good bone stock, and the other criteria which Sudhanshu was mentioning. Okay, here, bilateral total knee, multiple infection, multiple procedures. That's what I'm going to present here. In 3 years, had a periprosthetic fracture on the left side. And this doesn't look like a traumatic periprosthetic fracture. She had a revision left TKR. Few days later, developed periprosthetic fracture of the shaft. Operated for open reduction, internal fixation, and periprosthetic plate fixation. Unfortunately, that failed too, loosening of the implant. Revision was done with ORI. Revision ORIF was done with wound debridement because when they opened, they found that there was infection. There was a recurrent discharge of pus from the thigh and knee and was advised amputation of the limb. And that is when the patient came to me. Bharat, any point? What would you do? We only have 1.5 minutes, so we'll go quickly.
I think, to be honest, I'm very pessimistic. Maybe call in a tumor surgeon to try and do the whole LPS sort of a thing, if at all the patient is keen to preserve this limb.
Yes, so that is what we did. You're right. I think I first did a debridement, took the whole thing out, put a cemented spacer right from the hip to the knee, And at a second stage, when everything was clear, we went in and did a tumor prosthesis with constrained THR and TKR with MPT tibia done. We've done 3 cases of this. And this patient had multiple other problems, but here she is walking and infection-free. So this is where here, I think we have 38 minutes. And Kalai, any point that you wanted to make? Otherwise, I'm going to leave you all behind with a quote from Abraham Lincoln.
May I quote this? If you have 6 hours to cut a tree, spend 5.5 hours. Yeah, there you go.
That's quite a lot. I think you spend but the point is that sufficient time should go in planning, and I think it should apply to the infection treatment in total knee arthroplasty. Thank you very much, Kalai, Subhranshu, and Bharat.
Thank you.
Thank you.
We are exactly on time. Thank you.
Thank you.
Thank you.
Rajesh, that was a fantastic moderation. Kalai, Subhranshu, Bharat, thanks for those inputs. And I hope we don't see such infections that Rajesh has managed. And now may I request my good friend, Milind Patil, to tell us whether we should be worrying about osteoporosis before joint replacement surgery.
Thank you, Nilen. I'll just share my screen. Can you see my screen?
Yes, we can, Milind.
Yeah. Thanks, Nilen. Should we worry about osteoporosis before joint replacement? The answer is yes, because sometimes in the immediate post-operative period, if you get this kind of a gift in the post-operative X-ray, then you are definitely cutting a sorry face and going to manage it post-operatively. So osteoporosis is a silent killer. It can ruin your result. But what should we look for? In a preoperative examination, there are some pointers which can tell you that who are the patients who will fail because of osteoporosis. People with multiple comorbidities, people with steroid intake, rheumatoid arthritic patients who are bedridden or immobile for a long time, they are very osteoporotic. Sometimes there is a severe recent pain just above or below the joint. That means patient was having arthritic pain for a long time, but then suddenly stops walking because of some pain below the knee. These are the ones who are definitely going to develop a stress fracture. If there is a history of multiple fractures like fracture of spine or lower end radius, then they are also bad patients with osteoporosis. On the X-ray, if you see a poor corticomedullary ratio, that means the cortex is like a thin pencil-drawn structure, then those patients can also behave very badly because of osteoporosis. Obviously, renal disease and liver disease can also make the bones very weak. Now, what do we do? Should we get a DEXA scan done in all the patients? I would do DEXA only if I'm putting the patient on teriparatide, because I want something to compare the result of my treatment. And it perhaps is not necessarily indicated in all the patients. But vitamin D levels we should do. Should we defer the surgery? Now, deferring the surgery indefinitely doesn't serve the purpose, because if the patient can't really walk, if they can't weight bear, their bones cannot get strong. Maybe if the patient is a very bad osteoporosis patient, you may put them on teriparatide for some time, for a month or so, but you will have to go in with an early surgery with certain precaution. And what is the treatment? Whether you give only oral or some injections as well. Now, there are certain precautions we should take during surgery. While doing a total knee replacement, we should position the patient very carefully on table, because sometimes if during scrubbing or painting, if the leg moves too much, then you may get a stress fracture. You can check the bone quality during cutting the bone. That gives the real indication about the bone strength. Don't use any force during surgery. Perhaps releasing more soft tissues is important, because if the patient is tight, is a tight varus, and if you don't release the MCL from the tibia or do pie crusting, whatever is the philosophy, you may suddenly end up with an epicondyle fracture, because the bone will give way rather than the ligament. And if you feel that she's too tight, then you may perhaps do a controlled epicondylar osteotomy rather than entering into a bigger fracture. You put the jigs properly. because the pins or the lug holes of the jig may move and your jig may malposition. So you may not realize it before you start doing the cut. If you're using navigation or robotic, your pin placement has to be very careful because that also can lead to a fracture. Don't hammer the implant. Use it gently with a jig. Now you must seed the implant peripherally, not in the middle. Don't cut more bone because more and more bone you cut, you are entering into a softer and softer zone. I don't use all poly implants at all, but generally, if you've got an osteoporosis, then avoid all poly implants. You can fix the base plate. You can fix the insert to the base plate on the nurse's table rather than in the patient's body. Because after cementing, if you are hammering the base plate or the insert onto the base plate, you may cause sinking of that base plate. You sometimes can use a short cemented stem in the tibia. Now, if you feel that the MCL may give way or there may be a small fracture there, you can put a screw prophylactically to prevent that happening. You perhaps keep the trauma system standby and even the constrained implant standby in the case of very severe osteoporosis. Post-operative treatment of osteoporosis is very, very important. We'll come to that after looking at the hip and other factors. Even in the hip replacement, you must do a slightly more soft tissue release than what you would do in a normal patient, because all this stiff and osteoporotic patient with protrusio, you may end up into some fracture. Avoid any force during dislocation. Sometimes doing a neck osteotomy in situ is a better option rather than attempting a dislocation. Obviously, don't hammer the acetabulum too much because you may get a fracture of the acetabulum, and it may be a wise option to use a cemented implant. Here also, you seed the implant peripherally. In case of femur, prophylactic wiring may be useful to prevent a big fracture. Again, during reduction of the hip, don't forcefully do it. Don't rotate forcefully. Keep the screws and wires ready if required. In general, be gentle during surgery. Go slow. Be very cautious. Be careful with pulse lavage. If you do too much of a wash, you may perhaps lose some reasonably good quality bone there as well. When you put levers and retractors, especially the levers for the posterior part of the tibia, be careful that you're not indenting too much on the bone, and be very vigilant about the bone quality. And aggressive treatment post-operative is very, very important. There should be enough calcium in the diet. About 1,000 to 1,200 milligram per day is what is required. If the diet is poor, you must supplement with tablets. Vitamin D levels can be checked preoperatively. If required, you can go for an injectable, or if the level is good, you can go for oral supplement as well. Physical activity is extremely important. Start them on early weight bearing as soon as possible. If you feel that the bone was very weak, you can put them in a long knee brace for some time, or even ask them to use a walker. But starting them to walk early is extremely important to get the bone strength. Calcitonin can be used as a nasal spray. It also has an analgesic effect. Biphosphonate are anti-resorptive and probably are most widely used. The hormone replacement therapy can also be sometimes used, but it's used only after consulting with the gynecologist and endocrinologist. The selective estrogen receptor modulators, like raloxifene, also have been used and they're quite useful. The tamoxifen, which was used for CA breast cases, actually had a better bone strength in those patients. The raloxifene has come into vogue after that. Denosumab is a new drug which is anti-resorptive, almost same action as bisphosphonate, but slightly more effective. And it is a better patient compliance because only once in 6 months. Yeah, just last slide. Teriparatide is a form of parathyroid hormone. It is pro-osteoblastic, but to use that, you need to rule out myeloma or any bony mets. It is definitely most effective. So if there is any osteoporosis, use wires. If there is a fracture, you may have to go for a constant implant with fixation. If you get a periprosthetic fracture of this type, you may have to go for a resection implant as well. Thank you very much. Sorry for the delay.
Thank you, Milind. Now we come to the first keynote lecture, and probably this is going to be one of very important topics as we get more and more busy on work-life balance. May I invite Dr. Mohit Bhandari? And I'm very, very thankful that he's agreed to give this talk. Mohit, all yours.
Yeah, great. You can hear me okay, I presume?
Yes. We can.
You can hear me okay? Okay. Okay, wonderful. Okay. So let me begin, if I can, just by thanking this group for taking the time and energy to allow me to present this talk. I'll do my best to keep it well within time. So let me start off with this question. 2014 Nobel laureate May-Britt Moser would spend hours of her childhood doing what? Now, the truth is, she spent hours and hours and hours documenting the activity of snails as a child. She was in the moment. In fact, one might argue that could a lifetime of moments like those have led her to her Nobel Prize in Physiology in 2014? And this is the point I'm trying to make in the next 9 minutes, my friends. I've had many, many years in the pursuit of research in orthopedics, analytics, large trials. But more recently, I've really come to understand how important it is that we focus and foster creativity, and with creativity, ideas, and with ideas lead us to better opportunities in our work. I've had many, many wonderful opportunities to recruit patients in multiple randomized trials. And in fact, if I look back on my career, I see papers that I would have never dreamt that our team would have been able to do, and honors such as the Order of Canada in my life that I never dreamed that would ever happen. But I do look back and wonder, I loved to sketch as a child. I loved to paint. I gave it up. I gave it up because I was in pursuit of my job, in pursuit of the future, rather than just focusing on something that I really enjoyed. Now, I'm not saying that I should have been a painter. What I'm saying is, by totally giving up those things that give us joy, are we giving up the opportunity to even have greater successes in our life and for those around us? Our dreams are not for sale, says this one gentleman, Craig Valentine. He says, are you too good to be great? And this are the golden handcuffs that I think some of us, if not many of us, at some point face. Our life is so good that to risk it being greater, we have to give up the possibility of the things we have. So a stable job, a good opportunity in research. If you want to do something bigger, you might fail, but you've got to take that risk. In fact, in a paper in the recent JBJS, I was asked by Mark Swinkowski, the editor, to write a piece on what's important, a look in the mirror. And he said, be honest, look in the mirror and be honest. And this is a quote from that I wrote: make time for the things you love to do now, because in a snap of a finger, you will find yourself staring into a mirror, regretting that you gave them up. In fact, the truth is, people regret the things they didn't do rather than all the things they did. There's not a single person listening or on our esteemed panel of speakers, and I've enjoyed the speaking this morning, that don't look back at some point and say, I used to do this and I was going to be very good at this and I gave it up. Why did I give it up? In fact, by keeping that, you may even be better at your job, is the argument I say. Some of you may know this young gentleman. He was the past chair of orthopedics in Boston University, Professor Tom Einhorn. He is an icon in the scientific arena in orthopedics. And he wrote to me after I wrote that paper and says, "Dear Mo, I'm now 71 years old. When I was 17-year-old, I played guitar in a rock band, but gave up music for the same reason you stepped away from art. Today, I'm the only member of that band who is not a professional musician. Thanks for publishing." And here he is now at 71 in his home, an orthopedic surgeon, an icon in orthopedic research, but still makes time now to do some of the things he truly loves. And here's the point. We all think that our job is just, you have to do the time. Well, if I spend X number of years, I will go from assistant to associate. When I spend my 10 years, I will maybe one day become a professor. And you move through this pathway. But the very idea of doing this in a role is problematic, because ultimately it's frustrating, right? We have decades of these career ladders that are bottom up, that the only way to get to the top is to do it one way, which is do your time. My argument to you, friends, is that we don't do our time, and that we think very careful about what we are doing today and the things that matter today. And they will invariably, I think, accelerate the opportunities for us. But so often we let the present slip away. We allow time to rush by, unobserved and unseized, and squandering the precious seconds of our lives as we worry about the future and ruminate about what's past. One thing that I always remember is this was the beginning of Impressionism. For those of you who follow a little bit of art, Claude Monet put this painting up called Impression Sunrise in 1872. This moved away from the absolute realism that people would spend hours and hours tediously looking over photographs and human beings and getting every detail to, I'm in the moment. In that moment, I have to paint quickly. Impressionism was about painting in real life. And in fact, now, as Cézanne said, right now is the moment, and the moment is fleeting. We must become that moment. Imagine this. Imagine if somebody gave you $84,600 every day, but for every minute that you didn't spend it, it went down to zero. So every day you have to spend it or it goes away. You don't get it. How many of us would change the way we think, change the way we use our time and how we spend? Of course, we would cherish every dollar. But the truth is, we have exactly 84,600 seconds in our day. And how many of those do we just squander away doing nothing? And we can't get them back. That's the problem. So this is a piece I wrote called Life Unfolds in the Present. It's been written on Ortho Evidence, and we've also published it on LinkedIn. And I'll make sure those links are available for those who have interest in this topic area. But this is about me. My younger self was so trapped in a blinkered adherence to the future that I rarely took time to just be, let alone enjoy what was happening right in front of me. Why? I would ruminate about life after school rather than simply enjoy learning. When you're trying to get into a school of your choice, all you focus is on your studies and you don't think about anything else about going forward. I would overanalyze the path to my first job rather than simply enjoying my surgical residency and fellowship training. And after getting my first job, I became fixated on my first promotion. The cycle was never ending, and I never seemed to relish where I was in a perpetual treadmill of where I needed to be. So psychologists tell us we should savor, take every moment and savor, an immersive focus on now. There's a 9-week study that says if we just focus on something every day, take a few moments, that is, staying in that moment, amplifies our abilities to savor that moment, and more importantly, makes us feel better about our life and generally have a better sense of well-being. So let me ask you this. What can you savor each day? Is it that morning cup? Is it that morning walk? Is it meditation? Is it just enjoying reading a small excerpt of a book every day? Whatever it is, don't give it up, friends. Because the truth is, successful scientists have highly integrated networks of enterprise. And fact is, the Nobel laureates are more likely to have more non-scientific activities than their non-Nobel laureate colleagues. So in fact, it makes sense. If you want to be more successful, we have to do more. We have to find those things that give us joy outside of our day-to-day work that will accelerate our ability to work. Remember, diversifying your life assumes that trust that the rewards will come. While intelligence has been steadily increasing, friends, creativity is declining. In fact, that decline is significant, and it starts happening after high school and post-secondary. University does not teach creativity. University teaches anti-creativity. We have to squeeze it out of us, and that is the problem we face. Most adults are less creative than our younger selves. 3 in 4 of us are for sure believe that we aren't living up to our creative potential. But here's the problem. Just as this interaction this morning is talking us about this important meeting, ideas are the currency of the 21st century. And great advances have always come from ideas. So here's my thesis. Innovation at its best is informed by our creativity. And creativity at its best is informed by our pursuit of ideas. So creativity, in fact, means all of these things. So saying isn't doing, doing is doing. This is what happens. You have to realize that you have to invest in more things. More work will not make you better at work. Having a good life means you have to ultimately pretend, in many ways, you have to, if you want to move to an exceptional life, you have to give up the risk of a good life. So ask yourself the following things. Try new things. Have fun. Invest in the 20% of the things that give you 80% of your joy. Never fear failure and know it's okay to start again. This is my list of the few things that give me joy. I wrote this down in December of 2018. I've rewritten my mission statement every year, and I write it. And for me, it's building a creative mindset through arts, academics, and adventure. And friends, the most important skill for the future will be the ability to reinvent yourself repeatedly and throughout your life. How are we teaching ourselves that skill if we don't get out of our box and start thinking? So remember, we have opportunity ahead of us and only regret behind us. The challenge we have is to believe we have time, which is cognitive dissonance, or act right now. Remember, Picasso didn't become Picasso until the very last part of his career. That last piece of work you see, which is reminiscent of the real Picasso, all of these were his phases. All of these were Picasso's phases. So at the end of the day, I urge each and every one of you to find that moment that is your Picasso moment, whatever it may be, and urge you all to think very carefully about how you can use creativity as you think about building your life. Thank you so much.
Mohit, it's Gaurava Reddy here. It's a wonderful talk as usual. And I always get jealous of you. Why can't I be like another Mohit? Not in scientific way, non-scientific. Why can't I pursue the goals which you do it? You paint, you art. I love to see your evidence-based articles every time. And I circulate them among my CEO club friends. You're one of the greatest speakers and you're one of the greatest boon to our research community and especially orthopedic community. It's a pleasure to know you and you keep continuing to enrich our lives with your thoughts. And I'm now inviting you again for the next year, 2023 physical meeting in Hyderabad. And I'm the president again for that. So you have to block your dates now.
I'll be honored. And all I ask is all of you friends, is to take a moment to really think about the things that can help you excel. That's all. And I speak to it from personal experience. Having been there, I look back and I say, look at I could have even done more had I spent a little bit more time pursuing some of those other things.
Wonderful. Nilesh?
Thank you.
Yeah. We are really blessed to be hearing this talk, Mohit. It was difficult to get you. Thanks for being here. And you have opened our eyes.
Thank you.
And now, if we may press on, we will be getting on with the next symposium. And may I invite Harish, a good friend again, dealing with periprosthetic fractures around the hip and knee.
Thank you, Nilesh. Can I share my screen? Yeah. I presume you can see all that, right?
Yeah, we can see you. Harish.
Now, periprosthetic fracture around hip and knee is quite a large topic, and it's difficult to cover all the aspects and nuances of this topic just in a matter of 29 or 30 minutes. So I tried to select some cases which highlight certain points. And I have got a faculty here who is going to comment on that, give their opinion. So we'll have some kind of a dialogue and a discussion over next 30 minutes. So I'll start without wasting any time, start presenting the cases. These are not standard cases which we normally see. We talk about a femoral shaft fracture or, acetabular fracture or shaft fractures on the tibial side after surgery, and various classifications of that. But these are individual cases, and I think it'll be interesting to discuss them because each of the cases tells us some different point and highlights certain things which are very important in our practice. So case number 1, this is a patient, a standard routine TKR for an Indian surgeon, deformity about 25-30 degree, flexion deformity and varus deformity. And 68-year-old female patient has severe pain. This was a surgery done by the surgeon. And you can see that she had a significant varus deformity. He has done TKR. She was walking around and this was about 4 or 5 months down the line, and she had just a little bit of a tripping fall, and this was the nature of the injury. So what do you think you can do, Vivek?
Right.
What would be the option to do in this? Hi, Vivek.
Yeah. So, as I heard it, this is 6 months down the line?
Yeah, it's about 5 to 6 months down the line. She was walking quite well. She, in fact, had gone out for some trip out of Bombay, and that's where she had it. She had a fall, and she had to be brought back to Bombay in a car. So this is how she was. So what would you do?
Okay, so I am presuming the overall alignment of the limb and the immediate post-op X-ray and all was well aligned.
There is nothing hidden in the above the knee or below the knee.
So my usual philosophy in this is, I just want to make sure is the implant stable or not stable. If that implant is stable enough, then I'm all for retaining that implant and go ahead and do a standard fixation. And in this case,
how do you make that out?
So in this case, you have a fracture which is going from, there is a fracture on the medial side and a lateral side, and there is no radiolucency or a touch of radiolucency that I see around. But what I would do is just certain ways to make sure that radiolucency, is it a sign of loosening or a background infection or anything? If I don't rule all that out and there's somebody who's walking around comfortably, I would say, then I would try and preserve that.
Vivek, it is just 5 months and she was walking reasonably well. There was no history of pain she had before the fall.
I would
get radiolucency so soon after. Yeah. Leo, anything you want to add?
Yeah, I suspect that the tibial plateau is loose, and there's not really much we can do in terms of deciding whether it is loose pre-operatively. I think the only way we can decide is postoperatively. Now, if I'm opening it up and then if I see that the implant is loose, there's no brainer. I think it has to be revised. I'm going to get as anatomical an alignment as possible, and probably stem it as well. I think the fracture line is short enough for us to get a good distal fixation. And then once we've got a good distal fixation in the stem, we should be able to realign the proximal end as much as possible and either cable it or put in screws, whichever is possible, and then wait for the fracture to heal. But if this implant is stable, which I think is unlikely given that the fracture line of the lateral tibial condylar cortex is kind of way off, then I would probably just use multiple screws and then if possibly a plate on the lateral side as well, and then fix it up. But I suspect that is less likely to be the case.
Okay, so this is what was done. The fracture was fixed on table. They used the interlocking screw proximal to distal. The distal long spiral was fixed by passing screw across it. And on table, surgeon took a varus valgus stress fuse to see whether there is any relative mobility between the reconstructed bone and the implant. And surgeon found, okay, it was not too bad. So they accepted it. They made the patient mobilize non-weight bearing for the next almost 6 to 8 weeks, then toe touch weight bearing for the next 6 to 8 weeks. And patient was walking beyond that. And gradually over 6 months, this is what happened. There was no healing and the bone started becoming loose again, and it opened up, and you can see that now there is a radiolucency between the implant and the lateral part of the proximal tibial fragment. That it definitely means that implant is loose. So 2 questions. 1, why do you think this happened? Number 2, what can be done? Who is the next one? Sanjay is there, right? Sanjeev Jain, is he there? I can't see on my screen. Sangeet Gawale?
Yeah, I am
panel
here.
Of 4 people.
Yeah, I am here.
Okay.
Now,
yes, Sangeet, go on.
The first X-ray, what you have shown, at 4.5 months, neither it is showing osteolysis around the stem, neither any callus. If you can go back 2 slides.
Okay, I'll go back to slide if you want. No problem.
Yeah. So here.
That's the first X-ray.
No,
that is the post-surgery.
The next one.
That is
here.
The fracture one. And that is the on-table Shyam picture of varus valgus. That's the one.
Before. The second post-op.
No, there is only one post-op. I don't have any post-op X-ray here.
No, the one before this.
Immediate post-op I haven't here.
The one in which you have said it is 4.5 months old fracture.
No,
she has come to you.
No, 4.5 months is this. She came with increasing pain, and then she came and consulted me. Okay, doctor, this is what has been done, and what should I do now?
No, the first X-ray in which you have taken an opinion from Dr. Shetty, that one. That
the immediate post fracture is what he is referring to. Yes, this one.
Yeah.
I haven't shown you that X-ray because I haven't put it here in my presentation. Though I have it with me. But immediate post-op X-ray, the reduction was like this. This was a Shyam picture which I said. And the surgeon had kept the Shyam pictures, varus valgus stress free, because that was his way of trying to find out if there is a relative movement between the implant and a bone after fixation.
Can you put the slide which has a question mark? Can you put the slide which has a question mark here?
That is the one.
You have said,
it is not fixed.
Okay, what you have said is this is 4.5 months.
When this is not 4.5 months. This is immediate post fracture.
Okay. So here probably you have a fracture of the medial condyle which has been addressed along with the extension, metaphyseal extension. She also has a lateral side fracture, the lateral column fracture of the lateral condyle, and she has a varus. Now, if you see the post-op,
that is the post-op.
No, yeah. Here, now your plate is off. The posterior part of the plate is off. It is not, along, or it is not on the footprint of the medial condyle. That is one. Even though the varus deformity has been corrected, and this has to be neutralized by a second lateral plate. So the reason why it has failed is inadequate fixation of the proximal segment, the proximal tibia. It is addressed by only 2 unicortical locking screw, which is inadequate in a situation where the patient has a bicolumnar fracture. We are presuming the tibial implant is stable.
So, what you say is quite right. The two thing is there is only bicondylar fracture and one side is fixed, and proximally there are only 2 screws fixing it. The second thing is there is also primarily the implant was kept in little bit of a varus. And when you fix the fracture with the implant in varus, when the patient start loading, the load is going to make the fracture open up again. So usually if you have got a malaligned implant and if you get a periprosthetic fracture, fixing that may not work because every time you load that implant, the fracture may be loaded in an abnormal way. So that's second reason why probably the implant didn't work out. It failed. I had to revise that with a long stem.
If I can just add a small point to that.
Sure.
I think the problem was on the lateral side, and that is where the loosening was. I think there was not much of a debonding on the medial side, but on the lateral side, it's most probably debonded
That's
already.
correct.
The cement bone
could have been fixed with 2 plates that may have been mechanically better.
Even if we had osteosynthesis successfully carried out, you still would probably be left with a loose implant on the tibial side.
Now,
so because the cement bone
probably
is already debonded on the lateral side.
Yeah.
Harish, since you have done it, how was the tibial stem? You have extracted the tibial stem. Was it well fixed?
No, the implant was completely loose when I revised it. The implant was loose, and what Leo has mentioned, the implant was probably loose from the beginning because bicondylar fracture, the implant must have been free in the center. The only way we could have probably stabilized it, it would have been by bilateral fixation, where implant may have stayed a little longer, but with one-sided fixation, the failure happened faster. Plus, the primary implant was kept in little bit of a varus position, which accelerated the failure of this fixation. So eventually, the revision was required in this situation. So this was how we did a long stem. She had a good functional outcome at the end. She is almost about 2.5, 3 years since then. She is doing quite well. So that's the alignment post-surgery. The deformity is corrected. You have got a straight alignment now, and patient is happy. So message is, if there is a primary implant which is malaligned, the abnormal loading may lead to failure of your osteosynthesis. You have to be careful when you try to preserve the malaligned implant. Another case, it's a case which has got...
Harish, 1 second.
Good. Yeah.
What was the reason to revise the femoral component?
The implant had failed and there was significant amount of laxity of the ligaments. She was walking on this deformed implant for a long time, and I wanted to give a little more stability, number one, and that is the reason when I use a constrained implant, because I had to go all the way down, the proximal metaphyseal part was significantly damaged because of the failed non-healed fractures.
So in the presence of a non-union, metaphyseal non-union, how do you judge a instability?
No. The intra-articular, after reconstructing, it wasn't looking very stable. So I wanted to be more sure, and I used a constrained design, and because of which I had to go for a long stem.
Do you mean to say that if on day one, when she came to you with that fracture, all what was required was only revision of the extended tibial component with the extended stem?
See, when you revise and you revise one component, especially in a TKR, you have to also look at the flexion extension gap. Many times, just revising one component may not on table look very good. Although theoretically, it is true that we just revise the tibia and leave alone the femoral component intact.
Harish, Dr.
I wasn't
Dr. Kelly Vince also agrees with you. He's put it in the chat box that it is better to revise both the components. Osteolysis is present. Go on.
Yeah, let's go ahead to the next one. Now, this is a case again, severe deformity, 73-year-old female, and it was fixed, it was treated with the TKR. This was a X-ray of a patient immediately after the surgery. Any comment on the X-ray? Unfortunately, I don't have a lateral view put here, but lateral view, there is no notching. There is appearance is reasonably okay.
I think
just quick comment. You can go ahead.
They probably had to do a lot of soft tissue release on the medial side and then ended up having a very thick poly.
That's correct.
Probably all to the joint line as well. Unless we have a lateral view, we may not be able to say that.
Come again?
I'm not sure from this view whether the joint line has been altered.
Joint line may have gone probably little proximal, because when you have severe deformity like that with a significant stretching of lateral compartment and lateral structures, and you try to balance the structures, you end up doing slight amount of medial over release. So your soft tissue gap normally become little bigger. And when you have got an expanded soft tissue gap in these severe deformities, you end up having a slight high level of joint line, because you cannot bring the femur that far down because it becomes difficult in flexion. Flexion become too loose then. So you have to accept some amount of high joint line. Otherwise, you cannot get an equal flexion extension gap in these severe deformities. So your observation is quite right. The joint line is slightly higher, especially if you measure from the tibial side. If you measure from the femoral condyle, it has not significantly gone up.
Harish, if I may, with this X-ray, the amount of release, it's almost drifting the leg into the opposite direction, almost to the point that the lateral condyle of the femur might give way with the valgus correction because of the medial overcorrection.
This was quite stable. I don't think it was not unstable knee. This X-ray didn't show any unequal space or a gap between them.
Okay.
Now, when this patient was walking within next few days, she went on 4th day, and while the stitches were still on, she said, I felt little uneasiness. I tripped a bit and I had a sudden pain. She didn't have a history of actually falling down, but she said my knee just gave way, and she came and this was the X-ray. Any reason, any idea what could have gone wrong?
This is what I meant, that the release has been done too much on the medial side and the lateral side is porotic. I have seen 2 cases where the lateral condyle just gives way because of the overcorrection that has happened. And maybe retrospectively, a stemmed implant in that correction may, if the correction was too much on the medial side, then you might have needed a constraint at that point, is what I would say.
Leo, anything you want to add?
Yes, in some of these very gross varus knees, you always find that once you've done your knee, you still find that your medial side is quite good. You've done a reasonable job. You're not really tight in extension, not in flexion, but your lateral side is still slightly lax. The moment they take it off from full extension and you've loosened up the posterior capsule, the lateral side is in fact quite lax. In such cases, nowadays I'm tending to kind of not fight too much, but put in some kind of a TC3 kind of a semi-constrained implant. That definitely, I feel that it definitely gives me a better insurance against instability, because I think I've burned my fingers on at least one occasion where I went ahead and did a CR and then ended up having significant laxity on the lateral side and some kind of a instability beyond 20 degrees of flexion. So I'm a little, this is probably one such case where I would have probably used a TC3 kind of an implant.
With a stem, you mean? TC3 by itself won't...
With a stem on the tibial side.
Yeah, on the tibial side.
But theoretically, of course, if you're using I was talking about the primary index surgery.
Yeah, primary, but she has broken on the femoral side. Tibia is intact.
No,
she
probably broke it because of some residual instability. We do not know whether there was any mid-flexion instability. We do not know, or maybe it could have very well have been a kind of a trauma enough for her to break a.
Sangeet, you want to add anything different?
Yeah, Harish, can I, if I may?
Can you?
Sangeet, go on, please. Sorry.
Yeah. Can you go back to the previous X-ray? Correct me if I'm wrong. Is on the medial side, if you see the distal femoral cut and the height of the femoral component, is it normal or there is excessive cement in between the distal femoral cut and the metal?
I can't judge that, but the distal femoral cut is little extra, because of which the joint line has gone up, as Leo pointed out.
Yeah, I understand that. But if you see the same side on the same thing on the lateral side, the femoral component is very close to that distal cut. So is this normal, or there is excessive cement on the medial side?
This may be a little bit of a rotational, X-ray appearance. I don't think there is any change. But anyway, let me go ahead, because otherwise we won't be able to finish. Basically, what happened is, when you have a patient with a severe flexion deformity, you do three things to correct that. You basically get a little extra distal femoral cut to get an increased extension gap. So you elevate the joint line by maybe 2, 3, 4 millimeters to match the excessive flexion gap there. You also do at the same time a little lateralization of the femoral component, so that you want to improve the patellar tracking. And because of the big flexion gap, you end up putting a bigger femur. So it has got a little bigger box. So eventually all of that leads to the component, the distance between the box and the side of your cortex becoming very less. And in many times it may just break and give way. The second thing is, when you use this box knee, the knee which is posterior stabilized knee, if you use a regular saw to cut the box, the saw can go slightly beyond the designated level of a cut, and you may make a notch there internally, and that can lead to actually fracture at the lateral condyle. And I've seen it happening a couple of times. So if that is happening, especially in osteoporotic bone, because most of these people, patients with bad deformities, are not walking very well, they are elderly female, and they do have osteoporotic bone. So in these cases, it is mandatory to stem the femoral component to add to the stability. These three things basically cause a fracture in that area, and probably that is what happened to this patient. So there is an excessive distal femoral cut to take care of severe flexion deformity. The bones were osteoporotic, we lateralize it, we upsize the femur. All these are surgical errors which we should not have done. And if we had to do it to balance a badly deformed knee, maybe we could have used a stemmed femur to prevent the fracture in that area. So this is something which can go wrong. So eventually we had to change that, and we had to go for a revision with a constrained design with a long stem on the femur and tibia. Let me go to the next patient. So basically, you have to be careful with your saw. You have to analyze the effect of those extra cuts or a component sizing, or you lateralizing the component to improve your tracking of the patella. So that's the message. Let's go to another case, quite an interesting one. Now, this is a patient. The right side was done long ago. She came to me for the left-sided hip, arthritic hip, severe pain. I had done a cemented, non-cemented component like this. It's a coral stem and non-cemented cup. Any comment on this?
The osteoporotic nature, I won't be comfortable with putting an uncemented cup in that scenario. But I mean, you've taken that call where the implant you felt was stable. But given the porosity,
would you be more worried about cup or stem or both?
So coming to the cup, one part of that was the uncemented nature of that, and this is a type C door. Then whether that would be adequate to kind of fill up that space in an uncemented situation. So those were my first things. I wasn't thinking uncemented when I saw the X-ray.
No, it's uncemented. Leo.
No. So that's what I meant. I wouldn't have done an uncemented implant in such a scenario with the osteoporosis?
I'm not really, as far as osteoporosis, if you look at the femoral cortices, I think we're quite okay. We're not really that bad off. If you've seen a really osteoporotic femur, you wouldn't really see that big a cortex there. So osteoporosis doesn't seem to be a severe problem. Yeah, I think it's a reasonably well-aligned implant. The femoral stem is probably in a slight varus than what I would like to have. But on the whole, it looks like a good implant. And then the Corail is such an implant, which if ideally used, you can go along with a slightly undersized femoral stem because cancellous bone is supposed to support it. But of course, if you have osteoporosis, you think that preoperatively a bone was softer than you would like, and you're going to put in a uncemented stem, probably treat the osteoporosis as well in the post-operative period.
Actually, on table, the bone quality was not too bad. So we have both cemented, non-cemented ready, and on table we actually judge by rotating the broach when it is in the medullary cavity. If the broach fits very well, it can move my femur easily. That means it has got a good stability. We go for non-cemented. If it keeps on moving and I reach the periphery, because if the cavity is good, many times these are the fully coated Corail implant, and many, especially in younger people, you can see a significant amount of cancellous bone all around it. It doesn't have to be a canal filling implant in this situation. So I was reasonably happy with this implant, and this is November 18. About 6 weeks down the line, when they come for the first follow-up, she told me, "Doctor, I'm getting pain in my hip. The pain isn't gone." And that's what I expect. Normally in any THR, end of 6 weeks, patient is usually happy, walking without any significant limp and comfortable. So I took an X-ray, and this is what I found. The implant has collapsed. It has gone down. There was a significant amount of almost about 1.5 centimeters shortening which has happened. And the medial side, the calcar has just opened up. Although on my immediate post-op X-ray, there was no evidence of any calcar crack or a fracture, at least not in a visible part of a bone. And she was having some pain, not significant. She was able to walk, but with a stick, she couldn't get rid of a stick. Question is it acceptable? What should we do?
I think it is time to revise this implant.
Leo, go ahead.
Yeah. I think it is time to revise this implant. I have had a very similar case. In that particular case, I revised it to a solution with a calcar replacement kind of a stem. But I think it's about time, because for some reason, obviously, the proximal fixation failed, either because there was probably an unnoticed crack at the time of surgery, which was not noticed, and that probably gave away with the lesser tuberosity, lesser trochanteric insertion of the flexors, or the stem is sunk in and then probably dislodged the lesser trochanter. So either way, I think it's time to revise the femoral stem. The acetabular side looks solid. I think we could retain that.
Sangeet, anything you want to add or different opinion?
The stem looks well-fitting now. So that means it was at least 2 sizes smaller if you see the first post-op X-ray. And this is a hoop stress fracture. Probably if it is at 6 weeks, it has to be intra.
Sangeet, I think the Corail is not necessarily a stem which needs to fill the femoral cavity. You can undersize it. If you have a tight enough fit, you can undersize it.
If you see this stem, if you ignore what has happened, if you see this stem in the femoral canal, this is the perfect size. But we achieved that at the cost of sinking.
Yeah, but again, as Harish was just telling, Corail is not a stem you need to have a canal fill. You can accept an undersized femoral stem. You need not get a scratch cortical fixation. The whole point of the Corail is that because your Corail broach it's designed to impact the cancellous bone, not remove it. So I think the problem was probably an unrecognized crack there. Probably there was an unrecognized crack in the calcar or the lesser trochanteric region, which probably gave away when we mobilized the patient.
So Sangeet, would you revise or would you say now it is better fitting, so let me accept it?
She must be having significant shortening. So
he has about 1.5 or maybe 2 centimeter shortening.
Yeah,
you can see there that the implant was originally at that level, and from there it has sunk to this present level. So it's almost about 2 centimeter shortening.
Right.
But the implant is nonetheless sitting very well. The metaphyseal wedge is sitting very well. The implant is sitting very well in the metaphysis.
So her pain has gone now.
Yeah, she has some pain, not gone, and she's limping definitely, and it's double limp. I mean, it is a shortening. She has got short limb gait, plus because there is abductor weakness, because there is a proximal migration of trochanter, functional proximal migration, because the implant has sunk in, so abductors are a little weak. So she has got some amount of abductor lurch plus a short limb gait. So she has a significant amount of limb, although pain is not very severe. Now, I discussed with this patient and I told her that the risk is the limb will never go down because you will always be short, and there may be risk of dislocation because abductors have become weak now because they are foreshortened, and there will be some pain which may go for a long time. And the patient wasn't very keen for surgery. She had come from out of Bombay. So she said, "Doctor, let me wait and see whether if any of these things happen, I'll come back to you." And eventually the patient went home and came back in 1 year later, didn't come back in between. I told her to do some abductor exercises, asked her to continue using walker so that she doesn't slip or fall or dislocate. And 1 year down the line, now this is February 20, she had no pain. She's walking nonetheless with shortening, but she has adapted by using about 1 inch raise on the size of the implant. And so while walking, there is no significant lurch apart from little bit of a abductor weakness. She is very meticulous about doing abductor exercises, very obedient patient in that aspect. So she is comfortable except for little limb and a shortening. And the implant has not sunk any further. And it's a fully porous coated, HA coated implant. So probably it is very well integrated now. It's about, I think about a month ago I saw her, because after this COVID started in India, 20 March, and I didn't see her for the next 2 years. I just saw her about a couple of months ago, and she's doing very well apart from shortening. So basically, I mean, I also advised her that we have to revise it, but she just didn't want to get the surgery done. So basically, human biology may surprise you. And the only good thing here was probably when you sink the implant, the risk is if the medial fracture is in a posteromedial side and implant rotates along with the sinking and the version changes, then probably it will have a much higher risk of dislocation. This implant sink just straight down without excessive rotation. So orientation, the version probably didn't change much. And then the patient was little lucky and is still using the same implant. The next case, we have got IT fracture, subcomminuted IT in an elderly person. A surgeon has done non-cemented bipolar for the patient. He has used ethibond, not the wires, to reconstitute all the proximal fragments. So you don't see any wires over there. It's an immediate post-surgery X-ray. That was the implant used by the surgeon. It's a Wagner implant, distally fitting, but not distally bone ingrown implant. Proximally.
Harish, I'm sorry, Harish, time is up. So if you can just show what was
I'll wind up this case. Yeah, sure. So this implant, initially the patient was like this, but within a matter of 2 to 3 weeks, the patient, when he was walking, this is what happened. The implant sunk in, there was probably undiscovered fractures and everything shattered together and implant fell down. We had to then remove the implant. We have to do a long stem cemented component and wire all the fragment along the proximal part to reconstitute the bone. It was a long stem C-stem implant with the bipolar. Patient was elderly, so we stuck to bipolar. We didn't have to change to a THR implant here because acetabular cup was not too bad. So we have to be careful when we use a non-cemented implant. A lot of people are worried about using non-cemented implant. A cemented implant in elderly people, many of them want to still use non-cemented even for a bipolar, especially in Bombay, and that's not a very good option. You should use cemented if a patient, even if it is elderly, the bone quality is not very good. So I think I'll stop here because the time is out. Thank you, everybody.
Thank you.
Thank you. Thank you, Harish, for that very interesting session and great messages. Now, may I invite my colleague from HN Reliance Hospital, Dr. Srinand Vaidya, to give us an update about the Indian Society of Hip and Knee Registry update. Dr. Vaidya, please.
Yeah, Nilesh, I'm just trying to put my presentation. Can you see that? Can you see anything on the screen?
No, sir. You will have to click on the share screen.
Okay. Can you see that now?
No, sir.
So we can only see you, Dr. Vaidya.
I'm just trying my best because
sir,
maybe the team can ask Dr. Vaidya how to get this. And if Dr. Vaidya, you don't mind, I would not want Kelly Vince to be hanging on. We can take his talk first.
Sure.
If Kelly agrees.
Yes, no problem. Happy to.
Yeah. So we are very happy to have Kelly Vince. He's got it.
There's the registry.
Okay. Yeah.
Yeah. So can I?
Yeah, please go on.
So friends, we're going to update the ISH registry, Indian Society of Hip and Knee Surgeon Registry. And I, as a director of the registry, have a privilege to share with you some of the very important aspects of registry, especially in view of the pandemic that the world just suffered from. So I would have to say this registry app was launched in 2018 Bangalore meeting by British High Commissioner, because NJR, who managed the British registry and one of the largest registry in the world, have agreed to do our registry program called as IJR. And I have a very formidable team here. It is chaired by Justice Sri Krishna of Supreme Court. I am the director, and there are a whole lot of youngsters who are trying to help me to make this program very lucrative from education point of view and some information. So this is some interesting data. Gujarat as a state leads, friends, 25,000 cases in a year, followed by Maharashtra, which is 10,000. Telangana, which is catching up with my formidable colleague, Dr. Gaurava, adding cases after cases. It's almost up there to 5,000 and progressing. So friends, we also did audit of the whole of the country just in terms of tier 2, tier 3 level towns. And this is very interesting. Amritsar leads 100% participation, whereas some central province suffer from no participation at all. And that's one problem we got to tackle. Friend, just have a careful look at the graphics. You can see in 2017, we are clocking almost 30,000 registered cases, though the actual ones are much more, and which we'll talk about a little later. Now, from this, we started going down. This is total knee, this is total hip. Almost 30,000, highest in 2017, and about 3,000 odd hips in the same year. This was largely possible because of contributing surgeons, which rose to very, very good numbers. Right now, we are 240 surgeons who are reporting to the registry and participating. So awareness, trained surgeons, availability of orthoplasty services in tier 2 and tier 3 towns, which I just showed, increasing health insurance, almost 30% up. And friends, the younger surgeon with a lot of gadgetry, robots, they are charismatic, young, dynamic, and pushing the numbers higher up in our registry. But the most important fact is the NPPA, which got the implant cost to 1/3 level. It got prime ministerial attention. And now the packages are so friendly that many T2, T3 are doing more and more surgeries as compared to the metropolis. Now, what happened between April 19 till 22 February is very interesting. You know, we had a peak in 1 month of February, almost about 4,000. We dipped down during the pandemic, and the Prime Minister declared lockdown. And then we came down, up again for the second wave. We came up, again down for the third wave. This is TKR, and almost same pattern repeats in the hip.
And this is the averages of the good time versus bad time. You can see 97% cases were lost during pandemic. They pull up. They can't go out anywhere. 2 years, they are confined to their homes with the pain. How do they tackle this problem? So look at what we have offered to all our registry people who are participating. This is the hip, same pattern. Again, second wave, third wave, going down by 97, 98%, almost nothing. So you can see what was the decline, and you can see the same decline was converted into opportunity with tremendous number of cases reporting. Almost the same pattern in UK with the graphs matching, and I'm sure all over the world, it must be having these 3 spikes which you see all the time. But these graphics are not just statistical exercise, friends. Registries help to mitigate. What we did is we found out the resurgence cases which come after the wave is over. And you can see the prioritization has to be done. We found out this wonderful paper which is on the survey, which can offer you which patients need urgent attention. So that is something which we are trying to help. And also, this is the program. Another thing is registry offers unmatched research opportunities. Imagine, friend, with actual number 2 lakh cases and 50,000 hip, 2 lakh knees, your huge opportunity for research. Please contribute. From 220, you are all the right to climb up to all 3,000, which can be included. Isn't it a great research opportunity? You can have multiple papers. Just now, we are less than 10%, and we are trying to improve the penetration all the time. Now, the right way to do would be to make it mandatory, as like all these countries, and there is a poor compliance. But friends, we are right on the track. Ashok Rajgopal, our managing trustee, has been doing a great job in getting us noticed in the big platforms like National Health Authority. Friends, I'm very proud to say we are the only registry program across the medical specialties who have been taken notice of, and this is a wonderful letter. Slowly, we are reaching the Prime Minister's office, and that would be the day where all 2 lakh cases that you see will be mandatorily in. We'll have a great research paper, and one day we will be on the top of the agenda of research. Thank you so much for the attention.
Thank you, Srinand. That was a very, very apt description of ISHK registry, and I hope we reach the Prime Minister's office soon.
Thank you.
Thank you. Now, may I invite our guest speaker from overseas, Dr. Kelly Vince. I have had the pleasure of listening to him on various occasions, and I've had the pleasure of seeing him operate as well. He's a wonderful surgeon, a wonderful human being, and we are all eager to listen to your advice to young or old arthroplasty surgeons. Kelly Vince.
Well, that's extremely kind of you, and it is a real pleasure to spend some time with my friends in India. I'm not sure if I'm the best person to give advice, but I'll try. As a brief biography, I was born in Canada. I was trained in Montreal largely by Joe Miller, later in New York City by John Insull. I worked for many years in Los Angeles, and then in 2008 came to New Zealand, and I now work in Whangarei in the north of New Zealand, a lovely community where we're responsible for the far north of the country. I'm not sure if not having grown up in a different culture, not having grown up in the same culture as my Indian colleagues, if I'm the right person to give advice. There are wiser people who can. I've tried my best to understand this broad and rich culture, but I think there are some things that are universal. And I think advice starts with valuing our friends. And we heard from Mo the importance of work-life balance. I lost, and I know you lost, a good friend, Shekhar Agarwal, last year. Here we are having fun together in Las Vegas. He's a man who worked hard, and I enjoyed working with him. I think his advice to us there in that sign is good. And it was always a pleasure to work with this man, and I'm very sad to have lost him, as I'm sure you are. One of the things I think Shekhar would have told us is to put our patients first. And if we remember to do that, it's hard to go wrong. So in all the decisions we make, that's important. If you're going to be an arthroplasty surgeon, I think we have to focus. And by that, I mean we have to focus on arthroplasty surgery Sometimes it's hard to pay the bills, but we have to resist the temptation to do a little bit of this, a little bit of that. And there will be some days when there's not quite so much work to do. I think the key to understanding and excelling at arthroplasty surgery is understanding biomechanics more than anything. This is the foundational science for us. Books like Paul McKay's Biomechanics of the Knee are formidable in helping us evaluate new technologies. How the joints work is tremendously important. I would suggest we should beware of biomimetics, or simply copying nature. Sometimes that works. Sometimes it works to imitate what nature shows and teaches us. For example, the hooks on this little weed were the inspiration for making Velcro fasteners. That was good inspiration. But if we want to fly in the air, we can't simply do it the way birds do it. Those kinds of efforts at imitating nature don't always work well, and certainly in the most sophisticated forms, we have to have new technologies based on the equivalent of biomechanics. And if we adhere to biomechanics, we also are less likely to be consumer surgeons. We need to solve problems with surgical technique. We need to solve problems with basic principles, not simply by buying the shiniest prosthesis or the most elaborate prosthesis that's available. We don't want to be, as surgeons, part of simply a consumer society. We want to be the surgeons in charge of the case. I would advise that we should be skeptical as well. We should pop the bubbles of new ideas that really don't make sense. And that's really the way to establish truth and facts. I saw this the other day. Don't believe everything you think. Not a bad guide in life in some ways, where we're flooded with ideas over the internet, flooded with ideas in orthopedics. Now, while being skeptical, it's terribly important that we're not cynical. And by skeptical, of course, we mean not believing everything we hear. And by cynical, I mean having a negative view of humanity and believing that people are out to do bad and not to do good. So we don't want to be cynical. We don't simply want to reject things. We want to stay open-minded. I think we need to have faith. We need to have faith in our abilities. We need to have faith in our patients. We need to listen to them and believe them. Faith in our colleagues, faith in our teachers, with that little veil of constructive skepticism, if you will. It's important terribly to keep an open mind. I mean, we don't want to be the person who's too busy to actually accept innovation, such as the wheel, for example. So there is this blend somehow of being open to new ideas without actually accepting everything that comes our way. I'm always reminding our trainees the importance of discriminating between our observations and our conclusions. And sometimes that's as simple as an x-ray that goes up and someone says, oh, this is a case of debonding. And I have to remind the trainees, what is it that you observed that makes you come to the conclusion that this is a case of loosening, for example? How do you know that your conclusion is accurate? How do you know that maybe this is not infected after all? Somebody said that if we were to grade the value of our observations, they take first place, they get the gold medal. The conclusions we might form from them come in second place, and the hypothesis we form comes in third place. So always very important, not only to discriminate between observation and conclusion, not jump to conclusion, but also make sure we have all the correct observations, whether it's diagnosis or research, to come to that conclusion. In terms of our clinical practice, we have to always suspect infection, as I know all of my colleagues who are participating in this session today do. It's very constructive. There's the skepticism aspect of things again. This knee replacement may have fallen apart, but we always have to be suspicious that maybe infection is there. And people like Jay Parvizi are teaching us how to understand infection and how to deal with it. It's terribly important that we have a disciplined approach to infection, that we not pretend that it isn't present. And there are very detailed guidelines as to how we should behave to eliminate infection. And of course, aspiration before giving antibiotics is always tremendously important. We don't want to discover infection at this point in time, of course, when we've just made an incision. We tend to worship the randomized controlled trial. It is high quality information. The problem is that the next patient who walks in the door just may not be identical to the patient in that RCT. The humble clinical audit is tremendously valuable. And by that, I mean gathering all of our own cases, looking at them critically and trying to come to conclusions. This is a disciplined approach to quality. And I would say sometimes that physics, logic, and common sense can even surpass level 1 evidence if we apply appropriate skepticism to some of the level 1 evidence that we encounter. We learn more from our failures, and we should embrace them and not sort of ignore them. We have to share them with our colleagues, as you have all done so very constructively today, asking other opinions, challenging ourselves, for example. This was one of the probably the most important papers that I wrote regarding my own work. You know, it's a study, but it's really basically a clinical audit back in 1995. And it was about the limits of press-fit medullary fixation in revision. It was all about, in my mind, my failures in revision surgery. And it led me to think clearly about things that I had done and change my ideas about revision surgery. My younger daughter often reminds me that I used to always kind of harass her about doing the right thing. Now, in her case, it might have been tidying up her room. But in fact, for surgeons, we often know what the right thing is to do, but it's difficult to do. And I think all of us, if we sit down and ask ourselves, what's the right thing to do here? And we acknowledge and admit what it is, we are more likely to do the right thing and not try to take shortcuts. Sometimes patients force us to take shortcuts, and we should avoid it. Albert Einstein is quoted as saying that most people say that it's the intellect which makes a great scientist, and I would add, or a great clinician. Einstein apparently said they're wrong. It's character. And this is the aspect of doing the right thing, which often means doing the difficult thing in a difficult circumstance. I would say we always want to be a student and not a teacher. I feel a bit embarrassed and awkward when people suggest that, oh, you should be the teacher and teach us something. I think the highest compliment anyone could ever pay me would be that I have been a student of arthroplasty surgery. I'd rather be the person in the audience participating in the discussion. And if called on to give a lecture, I want to be the student and go back and learn something new about it that I can share with an audience each time. You are always a student, never a master. You have to keep moving forward. And Conrad Hall, who is a cinematographer whose life work was looking at things, I think gives us good advice there. We have to take care of your patients. I started this little presentation by saying we should put the patients first, and that's how we should end the presentation. You also have to take care of yourselves. Mo Bandari gave us a brilliant talk this morning, and it is largely about taking care of yourselves. And that means taking care of your family as well for that all-important life-work balance. And we are very privileged as surgeons and physicians because we get to meet people, we get to meet them at difficult times in their life, we get to take care of them during pain. And ASAP reminds us that no act of kindness, no matter how small, is ever wasted. And remembering this on a day-to-day basis, especially on the difficult days when things don't seem to be going well, I think really pays off. So in summary, I would say we need to have an open mind, we need to have an honest heart, and that really is the best path to truth and doing the best thing for our patients. Thank you all. It's really a treat to be able to contact my colleagues in India again. And I hope that there may be a time we can all be sitting down together.
Kelly, good evening. This is Dr. Reddy from Hyderabad.
Yes, nice to see you.
Yeah, you came to Hyderabad 10 years back and did a fantastic revision surgery symposium.
Yes, I remember it well.
Yeah, so you will be coming again next year. So pack your bags and wonderful talk. And your Gray hair now much more.
Yes, well, so the people trust me. I dye my hair this color. It's usually quite dark, but they don't trust me if I look too young. So.
Wonderful talk, Kelly. It's a very real nuggets for the life. Wonderful. Thank you so much once again.
It's my pleasure. Thank you for having me. Look forward to seeing you.
Nilesh.
Yeah, Kelly, thanks a lot for that talk. So to be a good doctor, you have to be a good human being first. Now I invite another good. Yeah, I invite Dr. Sharan Patil. He's the chairman and managing director of Sparsh, the Human Touch, and he's going to talk about cost optimizing in arthroplasty.
Thank you so much, Nilan. Are you able to see my slides?
Yes, we are.
Okay, great. So the job given to me is to talk about cost optimization in joint replacement surgeries. Cost optimization, cost optimization is not quality compromise. That's the first real statement I want to make. Quite often it's confused. You cut corners and somehow decrease the cost. It never pays you to do that. And how can we optimize, and in Guruva's words, optimizing the compromise without diluting the quality is the key takeaway from this talk. I'm sure a lot of you people have read The World is Flat, and it clearly is interesting that the people who have large volumes have least amount of cost per surgery, and that's the paradox. And the quality and cost both get better with the larger numbers. I'm sure you heard of this term called bundled payments. This is very commonly used in the Western world. Bundled payment is they give you X amount of money, the insurance company gives you X amount of money for doing a joint replacement surgery. That includes readmissions, complications, and everything to go with it. So that's called the bundled payment. And it seems like a very big new terminology I brought, but I can tell you in India, it's always been like this. If you operate on a patient, if something goes wrong, invariably, you'll end up taking care of it. So how can you avoid this repeat admissions is also part of cost optimization. I've split this into preoperative, intraoperative, and postoperative ways in which you can control the cost. Firstly, it's very important to get all your investigations done as an outpatient basis. And this has to be a very well-rehearsed act. It has to be a protocol-based, and your pre-anesthetic checkup, anesthetist knows exactly what you want as a baseline. And in special situations, you go out and do more investigations. But as a blanket, you have to revisit and see this. Sometimes you would have added 1, 2, 3 more investigations, and they become a normal habit. And suddenly you'll realize that you're increasing the cost. And that's why it's important whether you're doing urine cultures in a routine way or just a routine urine is good enough. These are the things one need to optimize. Never admit a patient who's not fit for surgery. It will take 1 or 2 or 3 more days of optimization after admission, which again increases the cost tremendously. This is very important. I find myself having at least every month 1 or 2 patients admitted, but they cannot be operated and get postponed. They're coming from out of town, ready for admission, but this, if it can be minimized, it will be of great help. Very important to identify high-risk patients, optimize them, whether it's diabetes, whether it is a skin condition, psoriasis, cellulitis. These are the patients who should never get into the hospital, and these are the potential patients who will be outliers and squeeze out a lot of your resources if you're not careful with them and you have not optimized them before admission. This is a very important takeaway. These things are done extensively in most of the high volume centers. A very structured patient education, meeting the team before surgery, and the patient understands. A well-educated patient with videos, brochures, pictures are a pleasure, and they always make the whole thing more efficient. This is a time well spent. If a well-educated patient will stay less in the hospital, he understands, and the apprehensions are so much less. outpatient surgeries has become a big fad abroad. I'm not sure if that's good enough for us to do for our protoplasm, but to imitate their protocols of pain control and everything else certainly helps patients to go home earlier, better mobilization, and every other aspect. Maybe you won't send them home the same day, but even if you keep them for 2 days, it'll definitely help them to have a happier patient going home. This is something which struck me. In a high volume center, there are multiple surgeons who are operating. If you do not have an implant standardized program, you tend to overuse it. Where you don't need stems, you may use stems. Where you need just proximal fixation, you might start using diaphyseal fixing stems, and various things can go wrong. If you can standardize this and use optimally, that itself is a huge cost saving. This is a program one can design for individually to your institution. Definitely OT time can be reduced, induction can be in pre-op, and you have 2 operating rooms where you're operating. You can do it on a continuous basis by just having optimal place for inducting. Revisit rituals. Quite often we keep doing things which are not necessary. For example, the endo clinic has found the use of the antibiotic draping is unnecessary, and they've not been using it. And there are many things we do it as a tradition rather than any belief. One needs to constantly revisit to see what it is, and never keep opening as a big surgeon open all the implants. And always a teamwork will efficiently perform the surgery and take you home. Consumable costs. We have adopted what's called kits. Every surgery, after so many years of doing it, you know what are the requirements of the consumables. You make them kits and give it. People don't splurge in the operation theater and use excessively. Whether it is your blades, and if you go to the company and ask them, that very blade costs you 1,500 rupees, a blade which is not even reusable. There are many ways of optimizing it. You can get it in 300, 400 rupees. In large volume, that makes a huge difference. For example, jet lavage system. What we do is a simple one like this, and all we do is use a broken needle and splurt it like this, and it works wonderfully well. It's a 50cc syringe, and that does the job. And I find it gives you as good a wash, and we have never had problems. We've been doing this forever, and that's another reduction of 1,200 rupees. This is a very interesting study to see how cement wastage can be decreased. And I remember Ranawat saying, if it is a size 1.5 or 2, you need 20 grams of cement. If it is larger, you need larger cement packets. And reduce hospital stay, better pain relief using technology, and it is pretty cheap technology to reduce the pain, and blocks and local things always work well. Cost-effective home physiotherapy. Don't have to send somebody. Today, technology is good enough for us to visit the patients at home and monitor their progress. That can optimize the cost also. All in all, standardizing always helps without allowing a new fellow to over-investigate, overdo things. When do you do x-rays? What do you do? Everything protocol means the cost will come down. Thank you very much, Nilesh, for the opportunity.
Thank you, Sharan. That was a brilliant talk. And we should optimize cost, because cost is a buzzword. And may I invite now another gentleman who's an institute in himself, Vikram Bhai, who has become a brand, and his journey has been surgeon to entrepreneur to brand. So he's going to talk about his life story, and we are all ears.
Start. Good evening, everybody. Am I audible?
Yes, you are.
Okay. Well, I would like to dedicate this talk of mine to my great teacher, Dr. Dinubhai Patel, and from where my journey started in civil hospital, my orthopedic residency. I discreetly remember one event when we had 4 volumes of Campbell, and the second volume at that time had arthroscopy and arthroplasty. And in second year residency, I asked one of my teachers why we are not doing it and why we are not teaching it. So I was told that it is not meant for Indians. We Indians don't need it. So it was never palatable to me. I never accepted it. And that's why I decided to go out and learn it. So I never accept status quo. When I was in UK, I was in Ormskirk, which is very close to Wrightington. I used to very, very frequently visit Wrightington. And there I learned that how you do surgeries in volume and still keep the quality. After spending 2.5 years there, I went to Beth Israel North, where I was with John Insel, and in Birmingham, Alabama for 1.5 years. And then there I learned massive volume of work with as far as knees are concerned. I came back after 4 years and I kept on moving with different corporate hospitals, and no hospital was interested in orthopedics and nobody wanted to know about joint replacement surgery. So getting tired of it, I decided to come up with a small decent nursing home, which I came up in 1994, and I started my practice with 6 beds. And what were the challenges? Challenges were of every kind. There was no awareness in masses. People did not want this surgery because there were a lot of complicated cases moving around. Orthopedic surgeons never wanted to do it because they were very busy doing trauma. Other challenges were incomplete implant inventory. Dealers in Delhi and Mumbai would keep 3 sizes and minimal instruments. So it was very, very difficult to perform surgery at that point of time. And old implants, old plastics were often given to us. First time in India, we established class 100 operation theater with vertical laminar airflow. And this is the original photograph of 1994. My wife used to assist me and Dr. Bharat Gajjar used to assist me. That is how we started. We did a lot of small innovations like leg holder, bone graft taker, then OS needle, and that was all helpful to us. From there, we were very, very successful as a surgeon, as well as able to give world-class results, able to do all kind of bad cases, everything. Meanwhile, in 2003, I came across this article of Time magazine in 2003, which opened up my eye that India or South Asians suffer 15 times more osteoarthritis knee than Caucasians. And as such, procedure penetration was very low. In United States, it is about 90%. Even in India, as on today, it is not even 30%. So I expect India to grow in arthroplasty to a couple of million in 10 years' time. This large knee replacement, hip replacement will be happening in 10 years' time. So after being successful as a surgeon, it was important that something should be given back to orthopedic surgeons. And it came up to my mind that we create ISHKS, and then I contacted Pachore sir and Nandu, and both of them then took it up, and then all senior surgeons across India were contacted, and this was established in somewhere in 2005 and 6. By 2005 and 6, this is what we started getting because a lot of people were doing it. Not many people were fully experienced or well-versed with the procedure. And by then, I started realizing that it is not one person's work now. I have to create an institution. An institution is not a building, but the people. I requested Pachore sir to join us as a director of hip surgery. 4 senior consultants joined me 15 years back, Dr. Devdar, Dr. Ashish Sheth, Dr. Amit Kshatriya, and Dr. Kalpesh Shah. They are very, very formidable surgeons. I'm just showing one case that what we had been able to do is this case 5 times operated in UK in private setup, infected, and patient was asked for disarticulation. We replaced her hip, entire femur, and upper tibia, and she's still alive after 7 years. So this is what we are ending up doing. And we all will be ending up doing such kind of cases in huge numbers. We are operating 2 to 3 divisions every day today. So in 2007, we came up with this unit on SG Road, and then entrepreneurial journey started. Soon after that, I realized that there is a lot of unmet demand all over country. So we came up with nearly 11 units from Chandigarh to Goa and from Jabalpur to Ahmedabad. Now we have 11 multi-speciality hospitals, 8 cities, 500 plus doctors, 4,000 plus staff. We have 80 plus OPD centers, which covers not only all India, it covers Africa as well as Middle East. More than 120,000 joints operated across 11 units by all surgeons as a team. After doing this, in last 2 years, because of COVID, I was free thinking what next, how fast we can reach out to rest of the country and rest of the world. So we came up with Shelby Orthopaedic Center of Excellence. And we have been giving this franchisee out to all small and big nursing homes, as well as large cities and small cities. We have already started in Udaipur. We have signed up in Kanpur, Gwalior, Rajkot, and so on. We are working for nearly 100 such units in coming couple of years. Before 8 months, we bought over one company in United States making all the orthopedic implants, which is 30-year-old company with 50 patents. More than 100,000 implants implanted and 0 recall. So this we can bring it to our country very soon, as well as to the rest of the world also. They are selling it presently in Japan as well as US. The key to success: think big, dream big, build a team, build system and processes. I always take challenges as best opportunities and always look into the future, because that will secure your future. Thank you.
Vikram, that's a brilliant talk. Think big, dream big. But with 100 or more centers all over India, I think all of us will have to join you or we will be wiped out. I remember the day when I had visited Vikram in his first hospital. And at that time, a very prominent orthopedic surgeon who had come to see his center had asked him that people are not getting high tibial osteotomies performed by us, and you think that you are building an arthroplasty center. Do you think people are going to accept this procedure? And I think time has told us how wrong the previous orthopedic surgeons were and what is the potential of this procedure. Guruva, do you want to say anything?
Yeah, I have to say something. Vikram, it's a wonderful, so rarely we listen to you. In fact, I was waiting for this because when Neeraj and we were chalking out the program, when your name cropped by, I said, forget about it. This guy is difficult to come. Okay. But somehow Neeraj persisted and got you. It was wonderful to listen to you. But you didn't mention about your private jet and all this stuff. But Vikram, we all learned from you. Really, you put the Indian map on the international this thing in orthoplasty. And I visited you many times. I know your work ethics. And I know you very well from close quarters. and you're always an inspiration for me. And though I'm not as big entrepreneur as you, but in my limited extent, I always aspire you as one of my gurus in the orthoplasty. Wonderful talk, Vikram. You inspired so many people. Thank you so much.
Thank you.
Can I add a comment to Vikram?
Yes.
Yep.
I have just this to say. I have stayed with him many times. Every stay was full with brilliant ideas. I have one grudge. Why did he keep away? He's entering into the field of manufacturing joints away from me. And that grudge will remain, Vikram, because whether it is ISHK, anything under the sun, 20 years we have been discussing, staying, and the ideas are growing and growing. This one idea you kept to yourself. I felt very bad. Anyway, congratulations.
We need to press on. And we were talking about managing doctors' expectations here, brand building. And after that, we should be managing patients' expectations. So here we have a young Kushal Hippalgaonkar who's going to talk about how to manage patients' expectations.
Thank you so much, Dr. Shah. Is my screen visible?
Yes, it is.
A very good evening to all. I'm Dr. Kushal Hippalgaonkar from Sunshine Hospitals, Hyderabad. I'll be talking about managing patient expectations. So around 20% of patients who undergo total knee remain dissatisfied. Unmet patient expectations are one of the strongest predictors of dissatisfaction after total knee. Now, a good result need not mean a pain-free joint, rather one that meets a patient's pre-op expectations. Pain relief is considered the most important expectation, but the others are psychological well-being, return to baseline activities, ability to perform high flexion activities, return to social activities, among others. So none of us are going to operate a knee like this. We're all going to stick to our principles. We're all going to operate it well. But there are other factors, and we need to take care of these other factors. If we divide patient expectations, and I'll stick to total knee because total hip is a more forgiving procedure. So the demands, the expectations from a total knee are more. The expectations are divided, let's say, into outpatient and inpatient expectations. When we talk about expectations as an outpatient, the first time the patient comes to us and we entertain the thought of knee replacement surgery, the first question is, will my knee be pain-free after the procedure? And the expectation is, yes, it will be. It's like replacing a car tire. What's the difference? It's like an old worn out knee joint. You're just replacing it like you would do to a car tire. But we have to prime the patient that these two are very different things. A knee replacement is a big procedure, and the effort involved post-procedure, the time involved to get the knee from that stage to a stage where it is pain-free is a long process. The journey is hard, and it may not always succeed, right? Will I be able to bend the knee fully? Again, the expectation is, yes, the patients feel they can squat like they used to in their 30s. Again, A, they're not supposed to. B, it takes time, a lot of effort again, and that has to be informed and primed. Can I go back to pre-surgery level of activity? And the expectation is, yes, they think the knee is the only problem, and then they can suddenly start running around. But by this, in this age group, they're suffering from several other comorbids, muscle weaknesses, knee, ankle, hip issues. So it's not the knee that's the only issue. So we have to, again, counsel them about this fact. How long does the implant last? Now, most people expect that it will last the full lifetime. Now, that's true for those in their maybe 60s, 70s, but for the younger 40s and 50s, we must prime them about the need of a second surgery later in life. While the other three below, return to work, return to sports, and driving after surgery, are more of a Western need. In Indian, as Indians, as we operate more and more on younger patients, we must always touch upon these facts as well. And then the difficult questions, what are the complications? The expectation is that there's no complications because we're offering them surgery and that it'll go smoothly. While again, we cannot scare the patients away with a list of complications from your DVTs, embolisms, infections. There has to be some kind of a priming. So, a simple thing like, okay, there are complications. These are the ones, but it's 1 in 1,000. That makes it a little easy for the patient to understand that yes, it happens, but it's a rare thing, right? If it fails, is the second surgery equally successful? Again, they feel that the answer should be yes, but we know the satisfaction rates of primary and revision are different. At the same time, at this time, before the primary surgery, we don't need to go into the details of second surgery. So we can keep the patient happy with just saying that, okay, that's not a big problem. That can be done. A second surgery will be okay. And again, the favorite question of 100% guarantee. The expectation is that we'll say, yes, you're going to get 100% guaranteed success. But again, we know the fact, we know that's not true. So we can again tame it down and give them a number somewhere like 95, 99%. It need not be a scientific accurate one, but it needs to be something the patient will be comfortable hearing. Now, while as orthopedic surgeons, we cannot take out so much time in our busy practice to explain all these things, counseling is the key. So counseling and more counseling, the counselor is like a wingman, bridge between doctor and patient, spends time with patient and relatives, communicates in an informal environment. And this is what we've explained to our counselor to tell the patient. Explanation of the whole procedure, including hospital stay, the cost, the implant varieties, robotics, conventional, short videos, and then answering all the questions. This is something that we use to explain the pathway to the patient, where they meet the doctor here, then go for their pre-surgery testing, the physician consultations. If the cardiac problems are there, they have to go to the department. And then, this is what makes them comfortable and aware of what's going to happen. And some infographics about other things. So these are presented by the counselor. So it's like we've told them what the whole journey is going to be like. And again, patient's expectation as an inpatient. So where do I go first? How long will I be there in the theater? When will I move out of the recovery room? When can I start walking? So it's not like they've accepted the surgery and the job is done. We need to explain all these things. And again, this part of our infographic helps us, where once they get admitted, the patient care, he's going to guide them. Anesthesia, surgery, all these details are told to the patient by our patient care executives and explained this way, all the way to the discharge process. Other expectations in a bilateral scenario, why is one knee paining more? The expectation is that both the knees will behave equally similarly, but we know the fact that they're always different. And the importance of physio. Expectation is that surgery is everything, it's done, physio is not important, but we need to drill it in that it is extremely important. In fact, only 50% of the job is done. And of course, discharge, they feel that they should be totally comfortable by the time they go out of the hospital. But we all know that that takes a long time and that the patients have to just ambulate enough and go home like that. So the summary is that unmet patient expectations are one of the strongest predictors of dissatisfaction. Assume the patient has no clue about the surgery and its details, preempt the question or expectation and counsel accordingly. Counselor is the key, and the harsh reality of complications is unnecessary, but the subtle priming is fair. Thank you.
Thank you very much, Kushal. That was a great talk, and you have exceeded our expectations. So great show.
Thank you, Dr. Shah.
He has to exceed Nilesh because he's from Sunshine.
Wonderful. Now, can you see my slides?
Yeah.
So we will get to the next symposium, and I would invite Dr. Santani, Dr. Vaidya, Dr. Wagle, and Dr. Hemant Mehta. Good evening, friends. Thank you for being there.
Hi, Hemant. Good to see you.
Nice seeing everyone.
So here, there aren't too many rules. It's a little informal talk. So pre-op patient assessment, we have all heard that we should optimize. Now, what are the things that we are going to optimize? And maybe Sanjay will tell us. So there are these modifiable risk factors: hemoglobin, serum albumin, BMI, HbA1c, obstructive sleep apnea, MRSA decolonization, avoid tobacco, alcohol, dental clearance, UTI, assess the psychological status, and we heard a talk about osteoporosis. So does anybody have any remarks to make on this, Sanjay?
So, out of all the things that you have mentioned, I think all the important things you have mentioned. One thing is, it's an elective surgery. The patient should not be, shouldn't have anemia. Hemoglobin, your BMI, you can't really control. Some people believe that patients who are obese should not be denied the arthroplasty surgery because that actually improves their quality of life. Diabetes control is a debatable thing that HbA1c less than 7 is not something which is absolutely required for the success of surgery. And in fact, many patients will not have HbA1c less than 7. So as long as the HbA1c is around 8, the patient can go ahead with the surgery. Obstructive sleep apnea, yes, we should be aware whether the patient has obstructive sleep apnea or not. MRSA decolonization, I mean, that is something we obviously try to find out whether the patient has MRSA, and the commonest post-operative infection is Staph aureus, so we should try MRSA decolonization. No tobacco for more than 30 days, that's correct. Because there is no point in stopping the tobacco just few days before the smoking just before the surgery, because it can lead to more cough and expectoration and can lead to more trouble. So ideally speaking, no smoking, no tobacco for 30 days. Dental clearance in UTI is of prime importance to prevent post-operative infection. And yes, psychological status. So I think the previous speaker mentioned that there should be counselor, and we should obviously ensure that the patient is aware of what is happening and he's in an appropriate state of mind to undergo the surgery.
Hemant, as an anesthetist, do you want to add anything?
Yeah, I was about to say, preoperative anesthesia clearance is extremely important part, and even in the previous talk, Dr. Patil also mentioned, it helps in optimization of the patient, it helps in cost reduction, it helps in psychological status, and at our hospital, to facilitate all these things, we have developed a preoperative optimization and preoperative anesthesia consultation. So wherever the patient do answer a few questions online, and they get even a SMS also that if you have this many investigations with you, you can upload, so that the major issue gets solved. And once you saw, and then my secretary goes in touch with them in case if they are finding any difficulty, and we have already put it in action for Nilesh patients since last 2 weeks. We are evolving it as much as possible, and we hope that we come out with it in another 6 months in a much refined way.
So if supposing there is low hemoglobin, Dr. Santani, would you just postpone, or what would you think? Or do you think that it's okay to operate with transfusions? We can't hear you. You'll have to unmute yourself.
Yeah, in that list, it should be more than 11. That's what we mentioned. But in a lot of rheumatoid patients, you will find that it is very rarely so. So my cutoff line is if it is less than 8. And if it is less than 8, I will refer them to hematologist. And most of the time, they will give them IV iron rather than giving transfusion. As you know, currently, the whole world is anti-transfusion in orthoplasty patient because it is an immunomodulator and increases the risk of infection.
Right.
Cutoff is 8.
So malnutrition. So this is one marker, serum albumin less than 3.5. We are told that we should not be operating. So if supposing somebody has an albumin less than 3.5, Dr. Vaidya, what are our options? What will we do? Or how do you build up albumin?
Nilesh, this is a great question. I have been attending ISHKS meetings, and 2019 meeting at a symposium related to various factors which leads to PCI. And they have found out in a very randomized manner that albumin 3.5 has very high chance of infection. Now, what do we do to get it right? If it is 3.1, 3.2, I think post-operative orders might include giving either albumin or histamine, which is amino acids, which can be a good trade-off to have a safe patient. However, world community in joint replacement surgery have realized the importance of albumin is more than what we are talking about hemoglobin all the time. I agree totally with Dr. Samtani that for me, not 8, but 10 is just about all right.
I was under the impression that giving IV albumin, Sanjay, correct me if I'm wrong, doesn't really work much. So if somebody has...
Yeah,
am I right?
Yes, you are right. Albumin is basically, rather than just being a number, it just tells you that the patient is sick. The patient is not nourished properly, or if patient has got rheumatoid arthritis, then that means that the patient's disease is not completely controlled. Now, to raise a hemoglobin, albumin from 3 to 3.5, you will need to give massive amount of albumin, and that is going to last only for a period of 7 days or so, at higher level. So what I'm trying to say is that, yes, low albumin is a predictor of adverse outcomes. However, by giving albumin, you won't change the outcome. So basically, this is a patient who is a bad substrate. Unless his disease is controlled, or if he has other causes for the hypoalbuminemia, those things will need to be controlled to improve the outcome.
Right. We just talked about that the HbA1c below 7 may not be, that fantastic aim, and we may need to look at 8. But we see, and even, the diabetologists often say that you admit the patient around 2 days prior and we will control his sugars. Now, Sanjay, do you think that's a good idea? Should we be doing this? Because I think this is happening all over India.
So, first of all, HbA1c will tell you is basically an average of 3 months of sugars. So you can't change it in 2 days. That's number one. Second thing, if you look at the risk factors and the adverse outcomes, this is not correlated, or after arthroplasty, these are not related to HbA1c value less than 7. In fact, if you look at the guidelines, type 2 diabetes, we say acceptable HbA1c is 7 to 7.5. In type 1 diabetics, we want it below 7. For a surgical thing, now again, the HbA1c will tell you what is the average. It doesn't tell you what the sugar is at that particular time, and which is what is more important. So, and I personally do not believe in controlling sugars in 2 days, which are again going to go haywire after the surgery. So more important is that it is an elective surgery. It is better that the patient's sugars, that means the fasting sugar and the post-lunch sugar and post-dinner sugars, are an acceptable range, that is less than 180 or so, for few days prior to surgery. No point in admitting the patient for 2 days, give them insulin, get the sugars down so that your sugars are down at the time of surgery. But what will happen immediately post-op, you have no control.
Right. So I came across this interesting paper from the Parvizi group that it was, if it is higher than 7.7, they had a higher incidence of adverse outcome. And if the sugars were higher than 180, they had a higher incidence.
Yeah.
So BMI, Dr. Vaidya, is there a cutoff, or would you operate all comers? Should we suggest bariatric surgery?
No, my first statement would be obesity has a distribution. If it is around the belly and your legs are okay, there is a window that one can accept. But if it is down there, one has to be very careful. However, BMI above 30 is not a very good patient. Now, what do we tell that patient? To come after some years, after bariatric surgery, or we make an attempt? I think there is a trade-off there. And my last penny will be on those patients who have a belly obesity and not really extending to the legs.
So we have come across a lot of articles about higher complications. The higher the BMI, greater the complications. We should offer counseling and advise patients to reduce BMI, whether 40 is a cutoff. But if a person has undergone bariatric surgery and they are coming for replacement surgery, Dr. Samtani, have you done these cases?
Yes. I also follow the same guidelines. My cutoff is 40, but if the patients are not willing, and again, it's the distribution of the obesity. A lot of them have truncal obesity, but the legs are not very big. I'm willing to do the surgery, but I do tell them that what are the problems involved and what complications they can land. And only when they agree for surgery, I will go ahead. The foremost complication is wound healing.
Right. So how do you determine obesity which is non-truncal? Do you look at the distance between the patella and the skin on a lateral X-ray? How do you determine that, Dr. Vaidya?
I think...
or you just look at the leg and say that the leg is fat?
That's what, if the overhanging fat is in between thighs, around the thighs, and over the patella, I think it's a bad case to do. And my distance from skin to patella, if anything is more than 1.5 to 2 centimeter, you have a problem.
Okay. So I came across this paper, a symposium, does bariatric surgery prior to primary TKA improve outcomes? And we would have thought that it does, but apparently there are worst outcomes of infection and instability. So impact of bariatric surgery for the hips is better because it reduces pulmonary complications. So now this decolonization, Dr. Samtani, do you practice that?
I would like to, but it's really very hard to do in our kind of setup. But I think it's the ideal thing to do in all patients. But I don't practice it because of some logistic issues.
Right. Dr. Vaidya, do you have any complaints about your setup?
Nothing.
And do you practice this?
No, I think, Nilesh, whether it is sleep apnea, MRSA, dental, they remain controversial issues. And with a wonderful anesthetist like Hemant around, you don't need to really have a safety issue involved in all this.
Right.
I think
so
sorry.
Just for the audience, I would say that I ask all my patients to use nasal mupirocin. A week prior to surgery, I ask them meticulously to take chlorhexidine baths also. And one of the reasons is that no matter how much you tell them, they would perhaps not do it very, very diligently. So in case an adverse outcome is there, at least they have it in their minds that they did not follow the instructions.
And Nilesh, if you recollect, even at Reliance Foundation Hospital, on the day before surgery, or suppose even if patient gets admitted in the evening, the next day morning patient do get chlorhexidine bath.
Wonderful. So this dental clearance and UTI, as we were mentioning, that it is a little controversial. So there are articles which say that dental clearance prior to elective arthroplasty may not be needed for everyone. They say that even routine urinary screening may not be required. And what we often see, asymptomatic high WBC count or higher pus cells in urine may not really mean anything much. So treat only the patients who are symptomatically involved with urinary tract infection. Would you all agree with this, or do you do something different? Dr. Samtani?
Yeah, I would agree. In fact, we had a talk, we had invited microbiologist from Hinduja, and he said exactly the same thing what you're saying, that only if they are symptomatic, you should worry about it. And even if they have urine infection, the infection going to the joint, chances are 1 in 100. So I would only treat if they are symptomatic. If they are asymptomatic, I will ignore it.
Right. So this is, Sanjay, what your initial statement was. We are saying something different from what you had said at the beginning of the symposium.
Yes.
But anyway, so psychological factors. Now, are we in a position to judge that? Sanjay, are you able to judge psychological factors when you assess the patients preoperatively?
No, I am not, because my interaction with the patient that way is pretty short, and it is impossible for me to judge the psychological factors in that short interview. So,
yeah, as here the role of again preoperative assessment on OPD basis as well as preoperative assessment once patient gets admitted is counted, because once anesthesiologist assess the patient, I've seen it with all my colleagues. I've got a very big department with me, and most of the patients keep on asking them so many questions about surgery and a surgery related thing. And if an answer given properly by the anesthesiologist with over about 15, 20, 25, 30 minutes good preoperative examinations, many patients get relieved from the lot of psychological anxiety on the previous. And as a pre-medication, also we try to give them anti-anxiety medicine at night that gives us patient in a better frame of mind on table.
Right, Hemant, that's very good. I'll just add one thing that I was reading a lot for this symposium, and the consensus is that we should not be giving them anti-anxiety medicines. Just something to think about. So, Sanjay, we get a lot of patients with previous angioplasties and stroke and all that. They are on blood thinners, dual antiplatelets. So, some guidelines as when to operate, should we alter the drugs, risk, bridge therapy? What are the guidelines?
So, as far as the blood thinners are concerned, I will divide it into two. One is antiplatelets and the anticoagulants. So let me talk about the antiplatelets first. So antiplatelets you will divide into aspirin and the other group, that is your P2Y12 inhibitors, that your clopidogrel, ticagrelor, or prasugrel. Now, somebody who has had angioplasty and who has got a drug-eluting stent, ideally we want the dual antiplatelet drugs for 6 months after the procedure, unless it's obviously an emergency procedure. We are talking here about arthroplasty, which is an elective procedure. So, for 6 months after the up to 6 months after the drug-eluting stent placement, we should not be doing the procedure. In a bare metal stent, you can do it after a period of 6 weeks. Now, after this period, definitely one can stop the P2Y12 inhibitor, that is clopidogrel, for a period of, ideally for a period of 5 days, prasugrel for 7 days, and ticagrelor for 3 to 5 days. Aspirin, again, everything will depend on when the patient has had a plasty done. If the plasty has been done less than 1 year back, I would prefer not to stop aspirin. If it is more than 1 month and the patient is asymptomatic, then aspirin can be stopped 3 days prior to the procedure. So that's about the
very much
antiplatelet. Now, about anticoagulant, now we have got different reasons why we give anticoagulants. Nowadays, most of the patients with chronic atrial fibrillation will have anticoagulants. There is no need for bridging therapy, and these things can be stopped very easily. If the patient is on warfarin, you will need to stop till the INR comes below 1.3. In the newer anticoagulants, your apixaban, rivaroxaban, you will need to stop the medications at least 5 days, 3 to 5 days prior to the procedure, and there is no need to bridge if the anticoagulation is for atrial fibrillation. Now, if the patient has got a prosthetic valve, the things are very different, because you cannot stop the anticoagulant. So these are the patients who will require bridge therapy, and the bridge therapy usually will be a low molecular weight heparin, like enoxaparin, and one would use enoxaparin and stop enoxaparin more than 12 hours prior to surgery and should not be started about 12 hours after the surgery. So you get 24 hours of period when the patient is off anticoagulation.
That is a very, very exhaustive summary of this. What it basically tells us that involve or a physician or a cardiologist whenever you are operating on these kind of patients, and we should all do that. Now we'll come to anesthesia. Now this ERAS guidelines, I would say that everybody should read this. It is enhanced recovery after surgery. So Hemant's spinal epidural GA, and I think the choice is your choice.
Choice is always regional, and ERAS protocol, what you are saying, ERSA guideline is a very, very important guideline, and we must follow it. And it helps in early recovery of patient. It helps in early ambulation of the patient. It helps in giving patient off nearby mouth also, because post-operatively, within 2 hours post-surgery, I will prefer to give them oral fluids and all that. And in ERAS guideline, it is clearly mentioned that up to 2 hours before surgery, you can give them clear liquid, and specifically 2 hours before surgery, we should give them about 200 ml of high carbohydrate solution, which helps in bowel recovery much better, and a patient can start on oral liquids quite well. So along with regional anesthesia, I would like to prefer to follow the same guideline, and it will help a patient to recover fast. And I am constantly focusing on daycare surgery as taking TKR as a daycare surgery. Morning you do the patient, and evening or late evening patient should walk back home. So all this thing helps in forming a good team and to achieve the result.
Right. So I think this is a good message here, that we were all stuck on that at least we should be having 6 hours nil by mouth. But the recommendation is clear fluids until 2 hours before surgery.
Correct.
And that does make a difference in the patient's recovery.
Yeah,
so when we come to
Nilesh, only I would like to highlight one thing, that one has to really educate patient for this, because many a time just a clear fluid quantity is not mentioned, what type of fluid not mentioned, and all these things do lead to a lot of problems with the patient. So this has to be explained to the patients and has to be put it in a proper way of ERAS guideline, which is 200 ml of fluid, high in carbohydrate, taken 2 hours before the surgery.
Right. Thank you. Now, when we come to pain management, I think multimodal pain management is the buzzword. And probably, Hemant, you only answer this. Paracetamol, NSAIDs, gabapentinoids, opioids, or maybe we'll ask Dr. Vaidya what are his views.
Yeah, I think with better reagents, peripheral blockage of nerves, and reagents which can put you down in the anesthesia deep and out earlier, no starvation, early walking. These are all things that are improving results. Length of stay is coming down. My take is I give the patient Celebrex pre-operatively 4 hours before. After that, it is Hemant and his team takes over, spinal epidural, and then adductor tunnel or femoral. But there also they have some funny names coming up as per the newer trials. So I only say we are going as peripheral, as near the knee joint as possible. So I think that's all about it.
Samtani, do you want to add anything?
Yeah, we follow spinal epidural still, which is actually getting out of favor towards adductor canal block. That's again logistic. You need to have a license to have ultrasound, and not many anesthetists in our area are trained to give adductor block. But we remove epidural pretty quickly within 24 hours. So first 24 hours. And we also give periarticular blocks and follow the protocol multimodal, blocking the peripheral nerve receptors, spinal thalamic tract, and central, all three levels.
Right.
Yeah. Nilen, here I would like to tell them something more about all this, which I have always seen these patients from a different point of view. And whenever the pain management with the arthroplasty is concerned, my method, they always raise with the controversial thing. But Dr. Sanktani, you can tell your anesthetists to contact me and they should try this. I am giving anesthesia for knee arthroplasty right from 1990s, where it was in a very nascent stage. And believe me, since 1996-98, I have started using buprenorphine intrathecal in 200 microgram dose, and it is converting my solution to 0.3% bupivacaine. Many surgeons are not accepting it because they have got a fixed thinking that it leads to urinary retention, it leads to this. Nothing happens provided I have got multiple literature. I will not start. I have got a full list in front of me, but I will not start enumerating all urological literature, urogynecology literature, even orthopedic literatures. But once you give buprenorphine intrathecal, at least for 36 hours, you hardly require any other multimodal analgesic. This thing, I and Nilen always keeps on contemplating about adductor canal block. If choice given to me, I would not like to give an adductor canal block. And I have done this with many surgeons. And as Dr. Kelly was mentioning, observation, first observe it and then conclude. I already observed in multiple patients and I'm convinced, and one of my DNB students is right now doing a thesis on it also. So,
Hemant, if I may just butt in here,
yeah,
the IRAS guidelines, which I have read since the last 2-3 days, do not encourage adding any opioid to the spinal. But although we can still discuss this further.
Yes, we can always discuss.
If we come to periarticular infiltrate or then generally ropivacaine, ketorolac, steroid, and some people add fentanyl. So which are the agents that you generally add?
Ropivacaine is we'll move on to answer.
I think Dr. Sanktani can answer this because
Sanktani.
Sorry, are you asking me?
Yes.
Yeah, my anesthetic is used for periarticular. I use bupivacaine, adrenaline, and steroids.
Okay.
But not in diabetic patients. I wouldn't inject methylprednisolone 80 milligram.
So if you go through the literature, they say that periarticular infiltration and adductor canal blocks, which I'm very fond of, are both are as effective on the first day. But if you have put in an ACB catheter, it can help you on the second day. Liposomal bupivacaine is not really cost effective, but combination of periarticular infiltrate and ACB can be a better regime. Now, what are the contents of PAI that can vary? And maybe Hemant, you can tell us on this. And I will tell you what I generally put in this also. Yeah. So Hemant, would you add all this?
Not everything, but ropivacaine, ketorolac, antibiotic, and opioid. And but natural dilute it with saline. But I would not use antibiotic and epinephrine in it.
Okay. Dr. Vaidya, do you want to add anything to this?
I would just say the methodology matters. 23 number needle, 50 to 70% should be injected in posterior capsule. And till today, I avoid steroid. So I have my own reservations for it.
Okay, so if you go through the literature, different people have added different things to this. And interestingly, these are the sites of the different nociceptors which are there in the knee. And they say that you should block each one of them, and these are the different zones where these injections can be given. I, like you, don't really, maybe I do not inject in all these areas because I had a steroid and I don't really want to inject near the patellar tendon. So I only inject in the posterior capsule. But these are the zones which can be injected. Now, NSAIDs. Dr. Vaidya, would you use NSAIDs for the post-op patients? Diclofenac, or you said Celebrex?
Yeah, I love Celebrex. But I think, Nilesh, the thing is, with wonderful job that anesthetists do and PAI, it is never regimental. It's all on demand. Patients are on IV perfalgan post-operatively. So that adds. But some of the off-patient who is painful, I don't mind giving NSAID or Celebrex.
Okay, Dr. Samtani.
Yeah, in fact, unless there is a contraindication, we routinely use diclofenac injectable for 48 hours. And after that, for first week oral, diclofenac with paracetamol and pregabalin if they tolerate. And after 1 week, then I shift them to etodolac and paracetamol combination and pregabalin if they tolerate.
Right, right. But obviously, we need to take precautions because the creat can rise. They can have some GI ulceration or whatever.
Only if they don't tolerate, we immediately shift to other NSAIDs.
Right. Now, steroids. Dr. Vaidya, you said that you are very, very hesitant to use steroids. Sometimes is your experience also?
It hasn't gelled into me that steroid is something which we were taught to avoid and given in any knee. And now we are giving steroid and trying to protect with a single injection with cefazolin or whatever. I don't think it makes sense. If other agents are taking care, for me, steroid is still no. And it's personal opinion.
Right. So your opinion is contrary what is the perceived wisdom? Because if you read the recent literature, they would say that perioperative dexamethasone does not increase the incidence of postoperative infection. And there are, meta-analysis and thousands of cases.
Let us do randomized trial.
Yeah, it is done. People have done this. You just have to read the literature. People have done this.
Yeah.
And I, for one, do use steroids. We all know that blood should be conserved and we should avoid transfusion. And tranexamic acid is the drug. And I'm sure that all of us use this. Yes?
Yeah.
Yes.
Yeah. So should we combine IV intra-articular and oral, or are you using only intra-articular or only intravenous?
Intra-articular and IV post-op.
Okay.
I only use intravenous.
Okay. So I probably use all three.
Tablet.
So any contraindications to tranexamic acid?
Patient with known history of MI.
Okay. Sanjay, do you say anything?
No, I agree with Dr. Vaidya. Anybody who has got a history of, coronary artery disease and cerebrovascular disease, one should be cautious with using tranexamic acid.
When you say cautious, can you use it or you should not use it?
Yeah. So if somebody has so when I say coronary artery disease, if this patient has got angina on and off, I won't use it.
Right. So
Sanjay, what about obese patients?
One can use it.
So not that I'm very, very knowledgeable medically, but again, reading for this symposium, the literature says that coronary artery disease is not a contraindication. Previous stroke, it is not a contraindication. And I have been using it routinely for all these cases without any adverse effect. But renal contraindications may be there. Patients with a high creatinine, this tranexamic acid can also raise the creat.
Yeah, dose adjustment. You need dose adjustment. And I also gave in all comers like you.
Right. So probably with this, we come to an end to the symposium. Does anybody want to add anything? The last
And the end of the conference, I suppose, or there is something
it is
left.
No, it is not the end of the conference. Let me stop share and see what else is there.
Okay. So Dr. Wagle, Hemant, Sagun, Hargun.
Thank you, everyone.
Thanks,
Thank you,
everyone.
Thank you to everyone.
Thank you.
Nilen, you conducted it very well.
Thank you. Thank you. Now, may I invite Dr. Leo Joseph to talk to us about the metabolic syndrome and hyponatremia in arthroplasty patients?
Good evening, sir. Let me share my screen.
I think we are running around 10-15 minutes late. That's okay, I think.
So, do you see my screen, sir?
Yes, we do. Yes, we do.
Yes, sir. So, at the outset, I should thank the ISHK organizing team, Dr. Nilen, for giving me this opportunity. It would be fair to ask, why would an orthopedic surgeon need to know about hyponatremia and metabolic syndrome? Every now and then we do have these issues in our patients in the post-operative period. And probably, though I may not be the right person to talk on it, at least I should be able to come out with something that will probably tell us what, as an orthopedic surgeon, we should know about these conditions, which might affect our patients. So it's not uncommon to see some levels of drop in sodium levels and our post-operative patients, especially the elderly who end up having major revisions, who have drowsiness in the post-operative period, who are less than active, and then you evaluate them and you find them to be low on sodium levels. Now, we often think that maybe that it's just because of the elderly age, probably, but then if you look deeper into it, there are more reasons than that. So what is hyponatremia? Hyponatremia is essentially a sodium level which is less than 135 millimoles per deciliter. May be categorized into mild, which is a 130 to 134, moderate, 125 to 129, and severe when it is less than 124 millimoles per deciliter. Now, quite often, mild hyponatremia is asymptomatic and pretty much may be ignored. However, severe hyponatremia can cause significant issues, including nausea, headache, agitation, disorientation, lethargy, confusion, ataxia, falls to the ground, seizures, delirium, focal neurological deficits, coma, cerebral palsy, Cheyne-Stokes breathing, and eventually death if unrecognized and untreated. There is also an association of hyponatremia with wound infections, pneumonia, and cardiac events. So almost immediately it is obvious why we as orthopods need to be worried about these in our elderly patients. Now, there are reasons why this can happen. For instance, the fact that surgery is stress, and stress can contribute to hyponatremia. Stress can be an inducer of the secretion of antidiuretic hormone, which can lead to fluid retention. And stress itself induces changes in the cell membrane permeability, which can lead to a leak of intracellular solutes, which can contribute to a change in osmolality and hence a fluid shift, which again causes dilution of the extracellular fluid component. A few words about antidiuretic hormone, which appears to be a key element mediating most of the reasons why hyponatremia can be an issue in the postoperative period. It is essentially secreted by the hypothalamus and it is released into the bloodstream in the posterior pituitary. It acts on the kidneys to increase fluid reabsorption in the renal tubules, and it causes constriction and higher levels of the peripheral blood vessels, which also gives its other name, which is vasopressin. And in combination, it helps increase blood pressure. So why would ADH be secreted in and around the period of surgery? Well, during surgery, especially depending upon how extensive it has been, there is some amount of blood loss. Plus, anesthesia, as well as the loss of blood volume, can contribute to decrease in blood pressure, especially if there's a spinal anesthesia, or when the general anesthetic is quite deep, or when we desire some amount of low blood pressure to minimize bleeding and extensive revisions. We do contribute to a fall in the blood pressure, which is an important stimulator of ADH secretion, because its primary purpose obviously is to maintain blood pressure. AD secretion is also increased by various issues which we see in the perioperative period, which is thirst, because we quite often starve our patients preoperatively, nausea and vomiting, and pain, which are all stimuli which can contribute to AD secretion. As a consequence, this leads to a retention of fluid and hyponatremia. And if we add to this the contribution by stress-induced cell membrane permeability, leading to changes which further shifts and which contributes to fluid shift, hyponatremia can become a real issue to worry. More often, our patients are all elderly and may have comorbid conditions, which includes diabetes, perioperative, preoperative hyponatremia, medications with thiazide diuretics, chronic use of beta blockers, which are all factors which have been associated with hyponatremia, especially in these particularly elderly age group patients. In fact, this is one reason why in the preoperative assessment, which Elaine was presenting sometime before, I think it is important to look for the electrolytes as far as a preoperative matter of assessment, because one among the issues which has been associated with a poorer outcome, and especially with the potential for severe hyponatremia in the postoperative period, is the presence of preoperative hyponatremia. While in most patients, transient mild hyponatremia or fall in sodium levels is acceptable and largely asymptomatic, in those with the above comorbidities, hyponatremia may be severe, and if not identified, may become cause for worry. The literature itself is equivocal in terms of how important is hyponatremia in arthroplasty patients. There have been authors who suggested it was largely inconsequential. Two others, like Cunningham et al., who identified an incidence of up to 20% in the perioperative period in certain patients undergoing total joint arthroplasty. So what is metabolic syndrome? Depending upon which you read, there are multiple definitions for metabolic syndrome, but the most useful and easy to identify is this, which is being given by the National Cholesterol Education Program, Adult Treatment Panel 3, which has been updated by the American Heart Association. Essentially, what it says is metabolic syndrome is present if 3 or more of the following five criteria are met, and that includes a waist circumference of more than 40 inches for men and 35 inches for women, a blood pressure of over 130 over 85 millimeters of mercury, a fasting triglyceride level of over 150 milligrams per deciliter, a fasting HDL level less than 40 for men and less or 50 for women, and a fasting blood sugar of over 100 milligrams per deciliter. Sorry. Yeah. So why are we worried about metabolic syndrome? Well, it has been established that patients with metabolic syndrome are known to have a pro-inflammatory state, which is associated with an increased incidence of cardiovascular disease, thromboembolic disease, and colon cancer. Cardiovascular disease and thromboembolic issues are things that we are worried about in the perioperative period in most of our joint replacement patients. Moreover, the adipose tissue itself has been demonstrated to secrete into the systemic circulation markers of inflammation like interleukin-6, TNF-alpha, and CRP, and the hormone leptin, which all induce a pro-inflammatory state and mediate insulin resistance. And insulin resistance contributes.
Leo, can you make your concluding remark? Because
I'm
time
almost
has been
done.
up
I have
for a
only
minute
one
or two.
slide. I have one more slide.
All right.
Yeah.
Okay.
So insulin resistance further contributes to a pro-inflammatory state by inducing lipolysis and increasing circulating levels of free fatty acids, thereby setting up a vicious cycle. So no wonder then patients with METs are known to have a poorer outcome of pain scores and functional scores in the postoperative period. And there is a greater incidence of complications, including wound healing issues and thromboembolic phenomena. Delayed wound healing is a well-known issue that we see. In fact, these authors have documented the poorer results at 1 year post-op WOMAC scores with patients with MET syndrome. So in conclusion, osteoarthritis itself may be a consequence of a systemic inflammatory process. We shouldn't forget that. No doubt that a large majority of obese, diabetic, hypertensive patients with osteoarthritis do benefit from surgery. However, the presence of features of METs as well as hypernatremia may temper the results of surgery or may delay the rehabilitation process and affect negatively on patients' expectations from the surgery. Our knowledge of these issues must inform our preoperative counseling of our patients, as well as our expectations of potential complications. Hypernatremia is a potential problem associated with arthroplasty patients, given a large majority of them are elderly and must be proactively looked out for and treated appropriately and early. Thank you.
Thank you very much. Difficult topics, well handled. Thank you very much. Now we come to the last two talks of the symposium. I'm told that both the speakers are not live and it's a recorded talk. So may I ask the organizers to put the talk of Dr. Sanjay Agarwala.
Ladies and gentlemen, dear colleagues, I thank the Indian Society of Hip and Knee Surgeons for inviting me to give this talk. And if you're ever in Bombay, come and visit me. DVT, is it relevant in Indian patients? And I say it is, and I will explain why. Serena Williams, Hillary Clinton, Jimmy Stewart, they all had DVT. In India, Navjot Singh Sidhu had DVT and it came in the press. And even Dilip Kumar had DVT. So clearly this is a disease that does occur. I will talk about this and why it is not uncommon in India, how we have described in 2003 that DVT is as common here as abroad. We wrote about it in 2005 again. And PI in 2012 showed in fact that the prevalence of DVT was higher in Indian patients compared to Caucasians. DVT prophylaxis is required. And it's just the tip of the iceberg of what you see, because approximately 80% of DVTs are clinically silent. The risk of venous thromboembolism is present in this landmark paper. It's been described that from below, that VT is no longer a rarity in India. Pulmonary embolism continues to be suspected more often than it is diagnosed. Arthroplasty patients are at high risk, and in fact in hip and knee arthroplasty, Sunil Agarwal has described a 40 to 60% prevalence of VTE. Furca's triad happens in all cases. There is stasis because of the tourniquet, the post-operative, intraoperative immobility. There is vascular injury for nothing else because of the kinking of the blood vessels during the manipulation of surgery. And the hypercoagulable state occurs because of thrombotic factors and the potential of dehydration in patients who are lying in bed.
What the mind does not know, the eyes do not see.
So really speaking, if you don't believe in it, you won't look for it. That's what I got Parvati Khan to say. And the underuse of VT prophylaxis in India has been lamented upon. My friend Pinjala from Nizams in Hyderabad has talked about the need for prophylaxis and the need of knowledge that DVT can occur. Is it important? Well, look at the mortality that can happen if you have an acute pulmonary embolism. Look at the morbidity that can happen with post-thrombotic syndrome, pulmonary hypertension, valve damage, and recurrent DVT. So you need to prevent it if you can. We believe in a multimodal approach to DVT prophylaxis. I use the intermittent compression device, I use DVT socks, and of course I mobilize patients the same day of surgery. Pharmacologically, I find that whilst patients are in hospital, low molecular weight heparin, in fact dalteparin fragment works very well, and at the time of discharge I give them aspirin. The recommendations of the International Consensus Meeting on VTE, published in the JBJS this early this year, talks about the potential of preventing DVT by using 81 milligrams of aspirin. The duration of prophylaxis is very clear. Total knee is 2 weeks and THRs 1 month. DVT in postoperative patients happens even in India. That's a take-home message. DVT can be controlled and prevented. Another take-home message. And DVT can lead to death and significant morbidity. Hence, we should prevent it. So we have a multimodal protocol that I use for my patients in our hospital. We give them dalteparin sodium subcutaneously. We use DVT pumps. We use DVT socks. We use the principle of early mobilization. On the day of surgery, my patients are mobilized, and at discharge, we give them aspirin 75 milligrams, 15 days for TKRs and 30 days for THRs, DVT socks for 6 weeks.
Give us your magic pills all the time.
We got Helen to say this. If you have nothing else to offer, give them aspirin. But don't believe that it does not occur. DVT does occur. Prevent it.
Okay, and then we keep. Okay. Okay. That was a brilliant talk. And now can we have Arun's talk on acing the academics?
Good evening. I'm Arun Mulaji, and thank you very much for giving me this honor of speaking to you about acing academics in arthroplasty in this last talk in today's session in ISHK. I'm going to cover 3 things. What is research? Why should one do research? And how should one do research? So what is research? Research is what I'm doing when I don't know what I'm doing. It's a process of systematic inquiry that entails collection of data, documentation of critical information, analysis and interpretation of that data or information, leading to the creation of new knowledge and or the use of existing knowledge in a new and creative way, so as to generate new concepts, methodologies, and understandings. We've all heard of Donald Rumsfeld and his known knowns and known unknowns. So I've modified his statement and created a modified Rumsfeld classification of the purpose of research. So there are 4 categories. There are known knowns. These are things we know and don't need research. Known unknowns. These are some things that we do not know, but we know that we don't know them. And that's what we need to research. There are unknown unknowns. The things we don't know that we don't know, and hence we can't research them. And then there are incorrect knowns, the things we know but aren't correct, and that's an area where we can do research. So the purpose of research should be to inform action. And these are some papers that we've published which identify certain issues and inform action based on classification, on assessment of data. Research should also explain certain findings. For example, these are a couple of papers where we've tried to explain certain findings that we've noted in our day-to-day clinical observations. Research should also disprove myths or incorrect observations of fallacious statements and concepts. For example, it was commonly believed that you have to release the collateral ligaments for severe deformities, and we showed you don't need to do that. Or that, for example, obesity does not cause malalignment if you use navigation. It should predict certain outcomes. For example, which factors increase the risk of malalignment? In total knee arthroplasty is something that we investigated and published in CORR. Or for example, the prediction of leg length change in patients with varus and flexion deformity undergoing total knee arthroplasty. Research should also challenge assumptions. For example, we looked at whether we could correct deformity and achieve gap balance by just removing osteophytes in, let's say, a varus knee. Musashi was a very famous Japanese warrior, and this is a quotation from several of his famous quotations. It is said that the warrior's is the twofold way of pen and sword, and he should have a taste for both ways. And I've slightly modified it to say, it is said the surgeon's is the twofold way of pen and scalpel, and he should have a taste for both ways. And this is some of the research that we've done, and it has culminated in nearly 100 papers, 15 chapters, several patents. I've been helped. I've been a designer surgeon for a couple of implants and so on. So these are some of the benefits, and the impact of research is in your practice, in developing a presence, and for posterity. I believe that you become a better clinician, you can achieve better results, and you're at the cutting edge if you're involved in research. It develops a presence, and you develop a presence in journals, through your books and chapters, through editorials. You're invited on the podium to give orations, to be part of the faculty, as well as a presence in academia. And for posterity, it helps others know that you actually existed on this planet. It has a lasting value, and you leave behind a legacy, and it may also lead others to do further research. For example, our papers have been cited by 3,500 other papers, and we have a high H index and an I-10 index. So the research you do does contribute to other people's research as well. And lastly is the question of how do you approach the subject of research. So you start off with case reports, then case series, then move up to comparative studies with controls, and then multi-center studies, and then RCTs or randomized controlled blinded trials. In order to do all these, it's very important to have the 7 following elements. One is to have a very clear-cut aim of your study, design your study appropriately, seek approvals from the authorities, particularly if you need IRB or institutional ethics committee approvals. If you need funding, then you may have to approach sources for funding. Determine your sample size, collect data, and collect more data than you would probably need, and then employ a statistician to help you analyze that data. Exploit technology in the form of internet, cameras, cell phones, and laptops. In order to find topics for research, look for lacunae in our knowledge, in papers, when you listen to talks and presentations. What is it that people say we still don't know about? And then try and answer those questions and develop critical thinking. Every question you're asked is a potential paper, and many of our papers have been written because our fellows asked a certain question and I was not able to answer that. So we said, let's investigate. And you must question everything. Just because somebody said you don't need scanograms in total knee arthroplasty, for many years people didn't do scanograms. And we showed that if you not do scanograms, you miss extra-articular deformity. And now everyone in the West says you must do scanograms. So unless you question people who say, oh, no, you don't need a scanogram, this would not have been possible. And always challenge assumptions. You cannot just assume something And you know the meaning of assume, it makes an ass of you and me. So the hidden value of research really is to see what others don't, to think what others don't, and to do what others don't. And research is the only path to excellence. And for many years it has been our motto, if not us, who? If not now, when? If not research, what? And I'd like to thank all my teachers, colleagues, co-authors, fellows, residents, collaborators, and patients in this long journey of research. But it's also been a very gratifying journey, and I think we've learned a great deal from our research, and I implore all of you to seriously consider doing more research and having some academic involvement in your clinical practice. Thank you very much.
Yeah, that's a wonderful talk by Arun. Nilan, are you there?
Yeah, I'm there.
Yeah, I think the guys stay for another 10 minutes. Thurston Garke sent one talk. Yesterday we could not accommodate. So can the organizers put the talk from Thurston Garke? That is exactly 10 minutes talk. It is courteous on our part to listen to the great man.
Good afternoon or good evening, dear friends, colleagues in India. It's really a pity that I cannot be there in person with you and attend your wonderful meeting. But I'd like to thank you for the invitation, especially my friends Guvara and Sharan Patil. And you really asked me to give a talk about past, present, and future of periprosthetic joint infections, and I tried to put it together in 15 minutes. I'd like to share my screen now and open my presentation. So let's talk a little bit about past, present, and future dealing with PGI and total hip replacement. As we all know, the periprosthetic joint infection is the worst complication in total hip arthroplasty and can end up in a disaster for the patient and the surgeon as well. The PGI is an ever-present danger, and this word of Damocles is always swinging over our head when we perform any kind of arthroplasty surgery. And the problem is, even if you are able to control the infection, then you are a loser because of more investigations, longer hospital stay, higher complication rate, and so on and so on. And it's unfortunately not only you are the loser, especially our patients are the losers. So let's go back in the past. I'd like to go back with you 53 years ago. 53 years ago, the founder of the Endoclinic here in Hamburg, Professor Buchholz, had the idea to admix antibiotics to the bone cement. Here you can see this original letter where he proposed the company who produced the bone cement during that time to admix antibiotics to the bone cement. And this was the birth of the one-stage concept, because his idea was that some antibiotics are able to elute from the bone cement. And already in 1973, almost 50 years ago, he published his first results by treating periprosthetic joint infection by using an antibiotic-loaded bone cement. And that was the first description of the single stage. Here in this very historical slide, you can see that he was able, by using antibiotic-loaded bone cement during this time in the 60s, more than 50 years ago,
to reduce the infection rate from about 6.3% down to 0.5%. Charlie didn't believe him, and he wrote a letter to Buchholz where he mentioned to him that nothing leaks out of a stone. In this case, Charlie was not right. And here's another historical slide from 1981, where my former colleagues here at the Endo Clinic described the surgical treatment in acute early infection. And they proposed a cleaning of the operating field and irrigation drainage for 3 days. And this is exactly what we call today DARE. So the idea of DARE was not born in UK in 2010 or 12. It was born already 30 years ago. What about the present? The present says that this two-stage revision in case of PGI is worldwide still the gold standard. The question is, why could the one stage not be the gold standard more and more worldwide? And this, by explaining you that it could be, I like to explain you how we perform a one stage at the present. First of all, we try to avoid an ETO. To remove our sometimes quite well-fixed stems, we use a very special universal extraction device. With this device, we can really get about 95% of our well-fixed uncemented stems from the top. We remove everything, including sequesters. We remove any piece of bone cement. We remove any piece of foreign body. We perform a thoroughly curate of the femoral canal. Additionally, we use a low-speed burr to clean the femoral canal. Additionally, we use brushed jet lavage. And here we use mainly an antiseptic solution, which is a polyhexanate solution, 0.02% concentration. And we need at least 3 to 6 liters when we use or perform the pulsatile jet lavage. After debriding the situs, and after finishing our debridement, we use antibiotic-loaded bone cement. Let me give you an example. This is Paul, 78 years. He was born in 1943. He came to us after a long history of surgical interventions, including several one stages, aseptic revision, and 2 stages due to repeated periprosthetic joint infection. He came to me in 2021 in this situation with severe pain. He was immobilized. He was sitting in a wheelchair. First of all, we did an aspiration, but here we couldn't find anything. It was a little bit suspicious, so we repeated our aspiration and found Candida parapsilosis and some other kinds of suspicious findings, like 3+ leukocyte esterase strip and a little bit elevated polymorph nuclear percents. So what next? We have a fungal infection of the left side with Candida parapsilosis. Fungal infections are on the rise. It is not really a big problem, but is an increasing problem. It's on the rise, especially Candida infections, where Candida albicans is the leading germ. So shall we go here for a DARE, a 1-stage or a 2-stage? In our institution, we perform and prefer the single-stage revision, even for fungal periprosthetic joint infection. We published our results already 8 years ago in the GBGS, where we did here in this case, Paul's case, an anti-infective therapy with 100 milligram amphotericin B and 40 gram antibiotic-loaded bone cement, and systemically he got fluconazole and daptomycin. I will show you how it worked. Here, a little movie. So first of all, we excite the old scars, and then we start with our really radical debridement. We remove any kind of suspicious tissue. We remove everything. And after removal of the soft tissue, we look at the bone. And if the bone is suspicious as well, that means if the bone is necrotic, if the bone could act as a sequester, we remove the bone as well. Here you can see all these kind of bone. It's really dead bone, non-viable bone. And then we use, as I mentioned before, this universal extraction device where we get it out. We clean everything. The canal must be cleaned very, very thoroughly. And then after finishing our debridement and removal of any kind of implant, we use this polyhexanide solution, which has to act about 15 to 20 minutes. And usually we re-implant a trabecular metal, a tantal cup, in combination with a cemented dual mobility cup. On the femoral side, we are using a modular cemented stem, not a modular uncemented, a modular cemented stem, which is covered with antibiotic-loaded bone cement as well. And then you can put it all together and you have a quite good and stable solution. Here you see the post-operative X-ray. Again, tantal revision cup, that's our normal way to solve these problems. Tantal revision cup in combination with the dual mobility cup, in combination with a cemented modular stem. Is there any evidence behind this? Of course, if you look at the literature, especially the most recent literature, you can recognize that they all show superior results with a one-stage exchange. And if you all put it together, some people are using one stage again, even in the culture negatives. The young patients can be also treated by one-stage exchange. We published our results here in patients younger than 45 years with a success rate of about 96%. Even in MRSA, you can perform the one-stage exchange. Our infection control rate is about 93%. And then we looked after the factors which are associated with re-revision after one-stage exchange. It's mainly, the main reason is dislocation and reinfection, of course. Dislocation is really a big issue, and that's the reason why we recommend, if we perform a one-stage, the use of dual mobility cups. Then we looked after our results in repeated septic revisions after a failed one-stage. In the knees, the 5-year course revision-free and survival is not very good, almost 50%. In the hips, it's much better, 81%. Why do they fail? Because of isolation of enterococci prior one stage and additionally isolation of streptococci. We looked at the failure reasons, and here we found again, streptococci are very risky for a one-stage exchange, more than 20% re-revision rate, and especially enterococci with a 37% infection recurrence rate is a dangerous germ. What is the future? The future is mainly about diagnostics. It's not so much about treatment. The future is in diagnostics, at least in my opinion, the next-gen sequencing. The next generation sequencing plays, in the meantime, a very important role in detecting pathogens in synovial fluid. The first publication about it came from Javad Parvizi's group, and later on he looked at his results by using next-gen sequencing as a diagnostic tool, and he could find that he could really detect and isolated organism in 90% of the former culture negatives. Another advantage is you cover and you can detect about 25,000 different species by performing and using net NGS. In PCR, for example, you can just detect 25 different species. Even the American Society for Microbiology is proposing it as a dramatically revolution in the clinical microbiological laboratory. And today in the US, and that's just the beginning, they provide the results of next-gen sequencing in 2 steps after 24 to 48 hours. They do the real-time and quantitative PCR for rapid detection. And after 3 to 5 days, where they target on the 16S NGS, they can give you a very, very good information about the germ, and not only the germ, also about the resistancy, susceptibility of the germ. The criticism about next-gen sequencing is always, do we have too much false positive? The answer is no, because next-gen sequencing is able to differentiate between dead cells and living cells. So the false positives due to contamination are unlikely. So the question is, for the future, will the one-stage exchange be the new golden standard? This is a paper from Sweden recently published, where they came, based on the results, to the conclusion that the single-stage procedure could therefore be the new gold standard for treatment of PGI in the hip. And the last but not least, probably the most important question for the future is, where should PGI be operated? We had this question during the last consensus meeting in Philadelphia in 2018. And the answer, the recommendation based on the literature was, patients with chronic periprosthetic joint infections are best treated in a tertiary care center, which was a multidisciplinary group of healthcare. That means these cases should be treated in selective, high-specialized hospitals. I wish you a great Congress. I'm so sorry that I cannot be there with you live. And many, many regards and greetings from Hamburg. Thank you so much.
Wonderful. Neelan? Yeah. Good evening, everyone. It is a great talk culminating the 3 days proceedings. And it's a real honor to be here. After 3 days, it's a wonderful feast of scientific content. And let me take this opportunity to thank each one of you, especially the 3 chairmen of 3 days, Arun Mullaji on knee day, Sharan Patil on hip day, and Nilesh Shah on the combined day. All 3 of you done exceedingly commendable job in getting the speakers together and taking the things into the forward perspective. And I thank my trustees and other seniors of orthoplasty, especially my Bhishma Pitamaha, Dr. Pachure, for being there all the time and helping us out. And I thank Dr. Praharsha and my other team in Sunshine for helping us out with the program. Praharsha, 3 cheers to you. You have single-handedly put all the speakers together. I know how much effort you have taken. I also thank Hallmark for making this such a seamless experience. So that is from me. And next year, before Dr. Pachure and Neelan put some remarks, next year we will be in a physical meeting in Hyderabad, and most probably it is the 2nd week of April, but we will let you know the date soon. Thank you so much once again, and I request Dr. Pachure to say a few words and Neelan.
Thank you, Guruva. Can you hear me, Guruva?
Yeah, we can hear it.
Yeah, okay. On behalf of the trustees and executive board, I'd like to thank Arun Mullaji, Sharan Patil, and Vijay and Nilesh Shah to put the scientific program well structured and informative. Also like to thank Dr. Guruva as the president to coordinate all 3 days with his great team. I must appreciate this great effort by his team. Must appreciate involvement of the faculty, especially national and international. In spite of the time problem, the international faculty has cooperated extremely well. I must thank the delegates for their involvement in the ISHK. Great job is done by, as Guruva said, the event manager Sheshadri and his team, audiovisual management. I'm sure we are going to meet physically in Hyderabad, that is 2023, and it is going to be a real mega event. Thank you, all of you.
Yeah, Neelan, Srinan, anybody wants to give a comment? Srinan?
I think it was a brilliant, well organized, and we have been well supported by all the speakers, the panelists, and the moderators. So I would thank Ish and personally thank Guruva, you and Pachure for giving me this opportunity. Thank you very much.
Okay, thank you so much. Srinan?
Vaidya?
Vaidya is not there, I think. Yeah, good. And Adarsh and Kushal, my young team. Suhas is there. I think he is not there. I really thank these guys for taking the torch forward. So 2023, Kushal, Adarsh, Praharsha, be ready, people. You guys got to rock. And Dr. Pachure puts a lot of value on you, young shoulders.
We will support Pachure, sir.
Guys, be ready for 23. The preparations start from tomorrow morning.
Of course.
Absolutely.
Okay.
Absolutely.
Okay.
We are
Thank
all
you so
there.
much.
We are all there with you.
Thank you so much, sir. Nilan, thank you. You did a wonderful job, Nilan. Though you said you are new to the things, but you conducted very well and wonderful. You're going to be a staple part of ISHK in the future. Thank you so much, guys. Everyone, bye-bye.
Bye. Bye.
Thank you. Bye-bye. Bye, Pachure sir. Bye-bye. Thanks to the audience as well. Bye-bye.